think yesterday I said that one of the foreigners so luckily for us, we have in our midst Dr. Minister of Medicine, who is with the IC, Institutional Education, who is in charge of clinical care. But it's one colleague I think I admire so much hard working for our family. And they are very grateful that this is our midst this morning. Like I said, it's also an extremely busy gentleman. But this morning we are so grateful that he's not going to be us a person. Dr. Drew, I'm most welcome.
Thank you very much. Thank you, Director, for breaking protocol. That is into the director. Thank you very much. I'm happy to be with you this morning.
Thank you.
Please, can we start with
Thank you very much.
Welcome back. And I'm also back. So, my name is still Maurice. And wow, yesterday, I asked why there was no questions and right I was saying that I related to but when I told him what's going on. I thought I had to ask a question. Please don't be intimidated. Today should be rather interesting. I mentioned yesterday that it's going to be like a continuum learning, so all of us are going to connect each other. We're going to cross the eyes of processes essentially. We ended yesterday with the AML surveillance, spoke about glass. So glass doesn't capture just AML trends, it also captures medications, trends and consumption and use. So we'll talk about it quite quickly, very quick, so we can move on to other campaigns. I'll just touch on relevance. We'll talk about glass again, and then AMS, and then classification systems and the sound sections. But to start from where we ended yesterday, where there was a conversation about movement and all, and that would have captured that I think a standard antimicrobial parts data. Because in your presentation, you spoke about the protocols that are designed. So if you have captured data on movements, then you have standard quality data to inform the guidelines that you want to do, because we're preaching that we want local guidelines because the dynamics of the AMR with geography is different for everyone. The foreign national experience different ones, the UK and the US. So this continues from that.
You are talking to the which is I thought most of us were
I'll try. So the idea about benches. So we go about the relevance. So we cannot have proper ESPs or antimicrobial stewardship programs without surveillance data on the infections and also the medications. Also the medications. So we can sometimes predict some of these patterns from consumption. You can see that we spoke about Ketrazone 2 grams yesterday. So we would have needed data to back that in. So if in your intervention you want to care that, you need data. You can't just say, oh, so consumption of Ketrazone facility or the opening was said when we didn't have the data to back it up. We'll see how that helps the strengthening. Just capture how we did about the action plan. So it compares the first one and the second one, the 5 objectives and the new 6. You see that surveillance and then remains over there. So SO2 for the both of them is surveillance data. So consumption and the AMR infection. It's going to feed into this one. And my colleagues will come and continue with that one, where there's access to the medications. Because the point is, if you do a culture, an example I gave, and then you don't have the medication to do physical tests, and then you don't have done too much. So we see that going forward. So the objective 2. So glass essential things it's a little outside us, at hospital and clinical care. It starts from like a national level, a regional level, so like a global level. So we need the systems, right? But the point is, when your data comes in, it goes into a pool of data. So Lecma is feeding to movements, some other people are feeding to movements, Kolibu, I think, UGMC, all those people are feeding to. So we get like the right people, what we can make some of these and routine. So it's expected of us to upload data all the time to class. That's the same sort of for using class. The conversation about lab capacities where we want to leverage technology. I don't know, is the lab expensive? Yes. Did you have, when we moved from lens to games, did you have any challenges in the lab data?
Yes, a lot of challenges.
A lot of challenges.
The reference ranges, and then I think even with the antibiotics, it's not all of them that are there. And then the isolates. There's a comment box, so that's the only type of it. Ideally, it's supposed to be there.
And also, we lost data when the sheets came from that. So, when we improve capacity in these areas, this is not supposed to happen. If all of us on bonus that time, we're going to prefer on stuff. So, I know we'll consider leveraging with AI also to make work easy for us. So, okay, that's about class essentially. And then it's like 3 parts. So routine data surveillance, focal data surveillance, and the service. We see that also going forward. Routine ones are there. Glass AMR, glass MC, consumption and then AMR. What's Dr. Paco did yesterday? Like I said, all of us are supposed to feed data to glass for that one. Then focused ones are where they focus on like emerging issues. Like if there's a particular change in trend or some antibiotic infection or antibiotic use, then there's a focus. So then there's a glass AR, that's the emerging antimicrobial resistant reports. There's also glass fungi, so to focus on candida, just because there's a surge in instance of those things. The service is, I asked about GPPS yesterday, the Global Prevalence Survey. It's also I think enhanced gonorrhea surveillance. All these ones go into survey, cross-sectional surveys are going to monitor some of these things. The aim essentially is to provide a common standard methodology for measurement and reporting. If all of us have a standard method, then we can compare properly. Because we really compare if you don't know how Shai Osu Doku affects data and how other facilities will solve. That'll cover it. So the objective is to integrate the package of tools supporting national AML action plans. So globally, there's a problem with the AMC data. It's only Ghana, and that's Assembly 2015. That issue came up. So the plan was to develop tools. That's where GLASS is coming on later, 2016, and also support the member states. We mentioned the secretaries yesterday who help us achieve some of these goals in the whole implementation process. So the tool is what we'll see going forward. Provide policy and types of consumer for policy makers. So that the information we get from this analysis also fits into those policy programs. So donations, and we're able to quantify how much to give you, and also to avoid possible expiries or loss of the already low resources that we're using in some of these programs. Offer common method. So generate reliable data. If we standardize, we know that we can release it and it will be reliable then it's standardized. Feed global MC data collection as part of GLASS. I think I've mentioned that before. Enable the comparison to benchmarking across different facets and different regions. So AMC data indicates the availability and affordability of antimicrobial agents. And this very easily we'll see it in our STDs, for instance. I mean, you see that there's a reason why some are in first line and second line, all those things, because they have to be accessible, they have to be available and affordable. If you design your own facility specific guidelines and then you don't have the indication, there's no point. So if all of us should have been able to establish the antiviral we're talking about, we're able to design those protocols, there will be small differences. When we were doing that some time ago, because we needed references also, like I was saying yesterday, some of the antibiotics that we regard obsolete just by feeling, or I feel like a master doesn't work in, I feel like it doesn't work in, I want to do that one. When you see the surveillance data, you're able to tell that indeed the ampicillin that you're writing off has some activity now or not. You see, very easily, our instance cannot be relied on in some of these situations. Because when you see the report, I'm sure you can bear with me on the report, you see it. The infection I think is so bad, and then, SIBO can do it. Well, you go and check it, something very easy, affordable can do it. When you are going around looking for what you think would have done it, what you want to. So I spoke about the national, regional, and global setup. So member states are supposed to get national surveillance systems that will coordinate the data collection at the national level. Then we feed it to the regional, so Africa, Asia, America, WHO, and then onto the global platform where better comparisons are there, better forecasting are there for some of these things. So there's setup, the structure, and so there's going to be a national platform, at least for Ghana. They're going to define our objectives, they're going to select the data sources. So Dr. Pablo also mentioned that certain labs were involved in the GLASS, so not everybody, just because of the viability and capacity, everybody has capacity to do some of these things. For instance, polyclinics, who might not have memory capacity, are able to do some of these things. But over the time, we encourage them to leverage other options. So there are some that I know that all their polyclinics, they use a third party. There's a lab, a private lab that's coordinates the data collection. It will come with its own problems. I'm happy that you don't support that because you have that inside there. ownership of data, accuracy of data because of documentation issues. So the objectives will be defined by the national teams. I mentioned they will decide the data sources. They will also collect and validate at national level before it's gone up. They will analyze. So that's when there's a lot of IT expertise, researchers. I'm glad you introduced your research team yesterday in your presentation. Sustainability is always a conversation with these things. Beyond certain projects, beyond whatever, we have to plan for continuity. So, antimicrobial use, that estimates the amount of prescription medications used dispensed to the patient. So that's data at the patient level. So that one, we're able to capture things like gender, age, the indication, and all those things. This is supposed to be the most accurate data you want to estimate antibiotic use. But that was given to the patient. So that is the most, but then it's rather sparse and difficult to get, this one. The hospitals are the closest, but there are lots of challenges in having to get this data. And because we can't rely on it, we talk about the consumption, also estimate, but they are rather standardized because it considers population and the specific time. So this will capture amount of medications from imports, from wholesalers, from distributors, from pharmacies. So you're able to catch in so 20,000 tablets of doxycycline, for instance, was reported into the system. So you can, it's a consumption data. But you see, the reason it might not be accurate is that those different the intersections in the value chain. So if it was imported here, it would have been given to probably central medical stores. They would have sent it to the region. Even among the facilities, I can give you some and you give back to me. And so there's so many gaps in those now, so it's also difficult to quantify. But we make room for the calculation. Like I said, there are estimates. So it might not be the actual number, but then gives us a fair idea of how much we're using. Then there will be no patient level data. And so we won't know what they were used for. But I assume that this was consumed because at the wholesalers level, we'll get the closer you are to the patient, the more accurate the data would have been. So just a proxy estimate of the antimicrobial use. Yeah. And it allows us to report anyhow. There's flexibility in the tool. So if you can't capture from private, you can just decide and capture on the public. And it was mentioned that when COVID came, and we used to see the updates on the TV or wherever, 10,000 tested. Remember that all of us were sharing those days too. Some of the concerns were the private people also reporting their cases. So we give an estimation or yesterday in the first meeting we spoke about how it was poor reporting on these things on the global front. So the close things. So we're able to just describe my data. If you have data for only community, you can do for only community. If you have only for hospital, you do for only hospital. Now, how we classify antibiotics? The ATC, the anatomical therapeutic clinical classification, is one of the methods we use. That's what we're using going forward. For the ATCDD system, where you see what it looks like. We don't commit so much to memory, but in 5 levels, level 1 to 5. And then because this is AMS and BTC, we focus only on the antibacterial. So we'll see only the gene. I mean, it doesn't look so nice, but it's what it is. I mean, we'll see a lot of it now going forward. That's how we, so the agents they are assigned codes, right? When we go to the DPS, we some of these things, they assign codes. That's how we identify the agents in all the consumption reports. So we won't write so much of amoxicillin or whatever, then they have like reference codes. So those are the levels. So all anti-infectives for stomach will have J. If they were antibacterial, J01. right? I'm bored because we shouldn't commit to memory event. Now I talk about the daily defined dosing system, right? Defined daily dosing system. This is an assumed average maintenance dose per day for a particular medicine used for its actual medication in adults. It's also it's a technical value, it's not like the real value. What I'm saying is that, and these are assigned, they are assigned by the WHO, there's a team, stats team that assigns the code to them, assigns the value to the medication. So an example can be 2 grams amoxicillin. That is the DDD for that day, right? But that doesn't mean that if we were prescribed, we can prescribe 500 milligrams amoxicillin TDS, that comes to 1.5 grams. That's the actual dose on the ground for the whatever condition you're treating for. But this one helps us to estimate how much you have used, for instance. So if the amount of, so if your patient gets, if your patient gets amoxil, for instance, right? Amoxil 500 milligrams 2 times a day for 5 days. That means that we're using about 5 grams, right? 1 gram each day, 500 plus 500 times 5. And then we would have been dividing it by the assigned value. So we're going to get 5 divided by 2.5 liters. So that is how we're reporting consumption, right? So it's a standard. I won't do so much about this. The calculation was the amount over the DDD, right? Reported at product level or at substance level. So how much bottles. That helps us to quantify the amount of medication given, and we're able to project consumption. So the sectors are divided under the systems are under sectors. There's the community and hospital. I mentioned that you can decide to report one side or whatever the description is. This becomes a pharmacy problem essentially. Because you could have, and this I was reading a research paper from Mampu. I think it was last 2 years. They did a study on the consumption data. Everybody is not trying to do that because we don't have proper data on it. So they, back in the days, we went at tally cards and all those things. That's how we can be able to find some of this information. So at community level, we would have had outpatient services. I'm saying that the OPD consumption would have been captured amongst community. So hospital and IPD, and also the pharmacies and the drugstores and all. So we can either report as community hospital of the total as part of the class. I mentioned the value chain just to show what it looks like. So from procurement and supply, your imports and manufacturing records with the bonus and then distribution, prescribing, dispensing, and patient use. The data is more accurate here, and it becomes like real estimates around the cycle. Right. All the data sources have their own challenges. I mean, if you should go to dispensing at private levels, no, private farmers might not be enthused about having to find work and coming from the data. If you have tried collecting data in your research, you see how difficult it is. Even a simple survey amongst health professionals, you see how difficult it is to get those things done. Oh, fill my Google form for me. We'll start on never finish. I mean, it's the same problems, but the same challenge. So that happens in the data collection. So there's a data management team. I've spoken about in they validate, they submit, they check, and then they tell us. Then we act. You see, if we don't act, if we don't provide feedback, we cannot act. And if we do not act, then we should have started in the first place. The same thing you see as AMS, identify a problem. If you don't act on it, then what's the point? You only highlighted the problem. It doesn't say anyone. So this I mentioned about, so this action was for all of us essentially. So the member states were encouraged to get their national AMC teams to get involved in this one, to help collect data, validate and map all them. And I mentioned that not all the facilities with data sources. So if you have capacity, you can be amongst those who help us estimate these things for us. Adopt the HCD. I didn't do so much because I think we'll get there. The idea is you are trying to build capacity for DTC in AMS, but then there are things that we do after going forward. We cannot have proper stewardship without adding consumption. I mean, you cannot have, because if you are going to enter for specific guidelines, you might need to see what's your consumption because you have available, so that in developing those documents, you can pick things on your shelf that qualify to go with expenses.
Thank you, that was excellent. Few clarifications. You spoke about reusing consumption data and not so much of the use data because it's kind of more convenient. Okay. And in that vein, you spoke about importers, like how much we import. And I know this is feeding into national data. Okay. So is it necessary for facilities, therefore, to capture consumption data, or the nation will use what is imported and what is manufactured as the proxy, or facilities are also required to take their consumption data? That is one. Then the DDD. So if facilities are expected to use their consumption data, they too equally can do it based on proxy, based on how much they bought or received. So like the supply chain data, just that. When does the DDD come in? And are they required to report it using the DDD or just the supply chain aspect?
Okay, so far the data that can be fed to classify is from importers, because that's where this system is not coming to all of us. I mean, in the last decade, essentially, to use. I was saying that your data is not is close to the patient. So the only place where the process accurate data is a hospital. If all of us are going to now submit consumption data reports using this one, that's will pull into national surveillance, and then you can get proper estimates. Because you can't rely on just in the importation, some will go into programs that might never see the hospital. Remember, ARV, recently they are bringing us medication that are very good, right? Some will go by. So it is around, it's close to the patient and data is more accurate. How much it gives to the patient, and we can see that was used. And I mentioned where there's movement across other levels of the value chain. So we're encouraged now. So if all of us in the country, the facilities have capacity to report that data, it's more accurate than if we're using the importation estimates.
So are they required to do?
Right now, it's a new conversation. So that's the action right now to build capacity in the ATCDD and then report like that. So that is where we are right now.
Okay, so about the DPD, is that what is supposed to be used to record the consumption data, or the tally cards like the supply chain amounts that we receive that can be used as proxy for how much we consume?
So we can use the tally card system to get. So that's how much we're going to quantify the one easier than how to do the dispensing one. Unless the gyms or whatever EMR we're using is able to do that. I've had that conversation with HR before. I don't remember how it ended, but then it was unclear to get I don't know if you're able to do that. Gyms. The new what DIMS and those ones to help us to quantify some of the data. The EMRs have to have the capacity for us to pull out and say that on the month of May we use them 2,000 kilograms of amoxicillin or any medication.
So just bringing it home so that it's clear. So are they to worry about the DDD calculation, or they are just to know it, but they will not be required to use it to calculate consumption?
No, so today, in today's one, we're informing them. And also because of where they are in the AMS journey, I felt like it would be cumbersome if we went into details. And I was mentioning before that for some of these ones, we would have focused on farmer-seller conversation. So if we're spending time to study the whole calculation, because we can use the EDD on per population, per bed stay. I just skip those ones because of the scope of the training today. That's right.
All right. So maybe you can also start the discussion. I think a good question you have asked. So the WHO last methodology for calculating AMC and all those things, it recommends capturing consumption data at all levels, at the national level, where we deal with import data that manufacturers also came out of, and also even export. Like Ghana, for example, know that some of the companies produce antimicrobial agents, the PIMA. PIMA also imports from outside. So we capture all that data, minus what was exported to other countries. So now it becomes the national data. That is what, like he's saying, is supposed to be fed into global PPs and all those. However, it is also advised that we capture consumption data at all levels of the supply chain, in the regional level, the district level, as well as the facility level. So that's what I would say. And in addition, what is about the DD? It can also be calculated at all levels, even the amount of medicine that I have taken as an individual. Like I was put on, like you said, 2 grams a day, Cetrazole for 14 days. Like I calculated. So it can be calculated at the individual level and also at the hospital level, as well as in the regional. I see in comparing, sometimes if you capture it at the hospital level, it is quoted that you use the OPD attendance as a denominator in calculating per, like this amount per this thousand population. If you also capture it at the regional level, then you can use the regional OPD attendance so that you can compare, like between all the regions, greater Accra region, between this year and possible Ashanti region. So I know how many animals are used along with the regional level. So that is my contribution to the discussion.
If we calculate DDT in festival, or how, what about combination drug and pediatrician? For pediatrician and combination of drugs, some 2-3 drugs.
So the ATC, it captures, so some of the gaps in that classification is that we don't use pediatrics, it's only in adults. It's only in adults. And there are 4 SARS, when it comes to combinations, they are coded for that one also. Some of the challenges too are that some might have more than one code. As I mentioned that it was a particular indication. So when the indications changes, they sometimes, so some have I think metro and one that other thing have different DDDs.
Yeah.
So that can happen, but there are the gaps in it. So you see, like I said, I'm trying to focus on where we can. So I'm trying to focus on hospitals. Like I said, at those levels we employ that quantification there. But because we won't use so much of, that's why I just focus there. But no pediatrics, unfortunately. No topicals. It's only for systemic use. I think I should have mentioned that it's for systemic use. Yeah.
Yes, I wanted to find out. So currently we are using the Gilmis to go and requisition to the regional medical stores. If the GIMS is able to, currently we're having challenges with reductions from our stocks. So if the GIMS can be linked to the Gilmis, is it possible we can know our antimicrobial consumption patterns? Because we are supposed to be consuming with the gilmist, we are supposed to be consuming in the system, which forms part of our appraisals or performance appraisal. So if, let's say, Shai Osu Doku district hospital, we take maybe IVCF triazole from regional medical stores, and we consume in the system, and gilmist system. In case the gilmist is linked to the GIMS, is it possible we can get our consumption patterns of antimicrobials?
But I'll make work rather easy for all of us. And that's what the conversation is. I mean, that's rather beyond some of us last at the time. But and it was only us, the lab also had no challenges. How to link to links that and so it's a, I mean,
It's in the pipeline.
Yes, so that is where the national organization is now heading towards. As I speak, there is this interagency steering committee that sits as the National Health Insurance Authority, NHI, all right, made up of Pharmacy Council, NHI, Ghana Health Service, to get me. If we recall, somewhere in 2024, there was this circular that was supposed to link up 4 platforms. All right, I recall that, and I named National Electronic Pharmacy Platform. All right, so that interagency committee is supposed to bring data from all these funds, from NHI, which uses claim it as the main software for managing claims. Then from the Ghana Service Fund, we're supposed to bring on board our games, links to this. All right, and then girls. The challenge with games or links to this and then games was the differences in the coding. Because of course they all have different codes, so but I think they're going on it, and we know that very soon. Then the third was Pharmacy Council also bringing on board the National Electronic Pharmacy Platform, so they can capture data from the private sector as well. So there are ongoing efforts to consolidate all that data from all those funds, so that we can have a national repository on medicines consumption in the country. And it's anticipated when that is done, when it comes to AMU, AMC, we can easily obtain data from that repository to look at our own as a country.
This system, will it come into the as indicators by the national user?
Yes, and then so okay, I should mention before we move forward. Then consumption. So you hear that our classification. I had a conversation yesterday. Access, reserve, and watch. So the global targets have changed. So consumption for access is no longer 60%, not 70%. And already we're struggling to make 60%. I think the Ghanaian average is like maybe 52 to 62%, which is fine anyway. Other inside more as well. So right now is a clear target and the new action plan. So 70% consumption, and that's how we calculate some of the consumption using that. So we see some of that inside as well. Yeah, that's there.
And the last information, we are here in the hospital, will we get access to that information as test people? Will we get access to class?
Yes, I shared in the data management was a dissemination. So there was feedback, a dissemination action. So when it's, like I said, we will have the most quality data amongst them, not regional medical stores, not central medical stores. We here will have the best data. So it's integral to the success of that.
So we will test people who will be
Yeah.
All right, and then also add to this. I think she has a very critical question as to whether it is going to use as one of our indicators. Yes, it's compatible. It is. If you look at the current reporting format that adapted at headquarters, you will see it is expected that when reporting on medicine concerns, we should use the ATC classification system. All right. Of course, maybe at the hospital level we don't do that, but at the regional level we pick it from the RMSs to the report on it. And based on that, they're going to calculate even the aware, look at the aware trends, look at the DDD, whatever, and they do the regional comparison. The issue with DDD is that because people haven't really understood the concepts, it will require a bit of time for that thing to be added. I recall when I was in Northern region as chief pharmacist, I added it to report for and I don't want to report it. Nobody did that. So all these workshops are geared towards building, raising awareness, building capacity. There will come a time that we are going to report on that at the hospital.
Yes, thank you. So, I mean, thanks for the presentation. I mean, the antimicrobial consumption, the use, the DDDATC. So I wanted to share with us, in summary, what's the relationship between all these AMC, AMU, and antimicrobial stewardship?
Okay, so the AMR, so surveillance, AMR, without identifying the trends, you don't predict where the problems are going to be. And if you look at our class, and also look at consumption, we look at our classification. So the molecules move across the groups. It comes to a point where we move it to our because we realize that we'll move it to reserve because probably there's beginning to have high resistance. And then the initial results. So access is where is the least risk of resistance. Mind you, it is effective for the condition, susceptible by the microbe is susceptible to the medication. And the reserve is where there's a higher risk of resistance, also still effective. And the last resort is where you want to safeguard because beyond that you don't want to give you antibiotics. So the consumption helps us. If we're saying that use is a major driver of AMR, then if we can get the consumption, do that, then we're trying to focus our interventions. So you can't have stick because consumption
veterinary people, they also veterinary.
I'm sure it's in the conversation.
Oh, we are working together.
We're trying.
Not yet.
Not yet.
We're glad there's movement and eventually we'll get to the finals.
You know, human health is far ahead of animal health. But they will surely get there. You know, the last time I heard about DDD, the first time I heard about it, I think it was in 2015 in Ashandi Radio, when Antima Taiko came to the village to do the submission of DDD. So the first time I heard about it. Not knowing that as far back as in 1969, and that's when the World Health Organization introduced the ATC and DDD classification system, and they've been using that thing since as a medicine, what they call it, reporting on medicine consumption and use. So 1969, get me. So some of these things, it takes time, but the way the world is moving now, I'm very sure that the next 2 to 5 years is going to cut across all platforms, especially in SME. We are going to report on it, labs will report on it, and after what they call it, agencies that deal with antibiotics. So very soon, we'll catch up. So the earlier we start building capacity and grading our GC, the better for us.
So very soon. We start with some person. Are there more questions? Okay, so then this one is Lala Hanson. W and the next one. And then so all of us here in the AMS committee and the AMS.
So I'd like to introduce head of administration. Now, yesterday she wasn't among us today. She said to join us.
Please rejoice. Bless.
So I'll add something before, without even asking Dr. Nye, I think we have to reach out to them for the proper going around the technical areas.
Yes.
So it was a quick decision because we're thinking that we need like a different interaction to do these things. So I'm saying we'll talk to the interaction accordingly. Also the women's trainings.
Yeah. But we will need the lab will need the training on the foodness so that they can enter data and then use the data to do the antibiotics. And pharmacy too, we don't think this with what he has presented, please can you calculate your DPs? Yes, so we think that there should be further engagement, so please reach out to us for that.
So we'll involve everyone in this one. And then I'm thinking how we'll sit. We'll do the same sitting like that. We'll give you some forms by you share. And then we'll use that to do the next activity. So usually I want a pharmacist and then
How many groups do you
have to I just change the assistant position.
Yeah, please, rearrange. We are doing 2 groups. So
Let's have 2
etc. manner. If we need to pause, we will pause for just 3 or 4 minutes to finish the snacks and then we will.
Start a conversation. The idea was to repeat this. Yours will come here today. So you are starting some MS activities. How long ago?
I'll deal with it. Yes. My boss,
training workshops and
So, like, when you ask for this come,
what's that activity?
like the research,
The research is one of them. You do M1 word rounds.
yeah.
I'm an M1 word rounds team.
we the farmers. So, our so
Okay, so then that fits into regular pharmaceutical. However, there is currently an M1 word round. I think rice thing is made before it's
We have to reserve that. Okay.
Okay, so like I was saying, the committee, the AML bonds are different from the regular, so you consider getting the same because you might also need to report. So here microbiologists get and I'll say you don't have to start the largest because you've got to start. It's flexible. But that's not something you have to start, otherwise you focus on just the antibiotics. So what it means that so I go on regular rounds and I go on AMR rounds. Separate. Those are the same. I see pharmacists who also go in there after this. You see more things when you do this as opposed to the word round that they can consider. I think that training is very helpful. And then the substance as you see some of these things. So then the global point prevalence level, what we call the PPS, PPS. Can you hear me? That's it's a process-known survey that we use to assess prescribing patterns at the facility. So I'll say that it's very easy to assume that I'm doing everything right. You see the data, and it's rather detailed. So 2006 FABA, the EU was serving us. They designed the protocols, and then the BRICS joined in 2009. And then from 2015, all of us have been encouraged to use that to assess prescribing habits at the facility. it's in both OPD and IPD. We do for both of them. OPD only came out 3 years ago. So before we used to do prescription audits, get like a simple Excel sheet, sample the prescriptions, and you tally the diagnosis, the duration, the frequency of medication, and all those things. This, of course, is a simpler way to do it. You upload data, and then the feedback comes. And you can see where your challenges are. That way, you can be able to focus your training session, your training programs, because it identifies what the gaps are in prescribing. Okay. Do you have the forms here?
We did something like that with Dr. Labon
What was it? You did something
in the audits.
prescription audits, but not the PPS. Yeah, that's nice. Yeah, share. You share because it's a number of documents. And also, we are going to form PPS teams. You are going to form PPS teams that will do the audits for you. Like I said, you should have a prescriber, you should have a pharmacist on the team. They will use those teams. The microbiologist. No, take it out. Take the simple base out. We'll be using them. Oh, no, one of them. Have one. No, all of them. Just one of them. This is open. Are you ready? So this is a free tool that will be employed to assess the prescribing habits at your facility. So a number of us are already involved in it, and it's almost worldwide. America has a different they have a different tool that they use. We're going to use this one. The protocol was designed by the University of Belgium. So they host the platform that you upload data to. The data everything is protocol. However, kindly stop me where you don't understand anything, because I don't do representation. I don't do slides. I'll preach from the spirit to speak to, and I'll speak to you. So aside being able to, aside being able to assess prescribing habits, they're going to assess the indicators across hospitals that are your type, across the country, Ghana, across Africa, and then you can compare to also Europe. Right? So we start from the IPD, the English. That's this one. You see word form and patient form. This document. So what happens is you form your groups, your teams, and the how many words are how many words are I was 7 words. 6, 7. So okay, that is I was 7 words. I did 7 words, so like 1 one room or one department?
One department.
So in the 7 wards, you have rooms. Okay. So in other 7 you have male and female.
Yes.
So let's say you have male, so 14 essentially.
So we have male ward, segment, female ward, kids ward, so emergency has
Okay, so you have surgery, OBGY, internal medicine,
Yes.
like that.
Yes.
Yeah, that's what I was asking.
within the wards.
Yes. Within the ward.
Yes. Female surgical.
Okay, let me ask. The female ward, is it one place?
Yes.
Yeah. Then you have
Surgical.
OBGY.
OBGY has own department of its own.
I'm asking because then we'll find a way to name those wards from the protocol. I'm just asking to understand. Other places is different. They have internal medicine, surgery, pediatrics, OBGY, and then they have second. No, I said the beds. I wanted to know what the structure looks like. See, this is a point of concept because once in the bed. So if you are going to have to address a big room, it means that you have to complete that in that day. Right? You can't go and come back because it will affect your data, the quality of the data. That's why I'm asking for some of these details. Right?
If, like surgical work, you don't have 2 people, but there are 10 beds.
Yes, we'll capture all that in the data. 10 beds inside there, we'll capture that in the data. There's no need for the patients because it captures prevalence, global prevalence, and then you can calculate that the number of beds that are there. So if you, for instance, example, if you go and say you have 2 beds, and you have 2 patients on antibiotics, that's 100%. So if you don't capture all the extra beds inside there, it will show that Shai Osu Doku have 100%. Everybody who works here has an infection, which might not be a proper
And
reflection.
then we have to take quantity all the beds in the hospital.
It is captured. I just want to understand what it is so that you yourself
If
fix
you want
it.
the actual figure.
But no, we'll do that so you see it. Yeah. Okay, so in this survey, for instance, we're taking data from patients who are actively on antibiotics, not those who have been planned for antibiotics, those who have been discharged. What I'm saying is that if you go there that morning to start your data, if they've been discharged, they are packing their things, they are not included in this survey. If their plan for hasn't started, but there's a doctor is saying, oh, remember antibiotics, they are not part of the survey. You don't also affect anything, you don't make an intervention, because it defeats the purpose of the survey. When you see the state of the hospitals, if you go and make the interventions, you get a false positive, so you avoid anything. So what I say is that you don't interact as much. Very little. There's a point where you have an interaction with patients or nurses, but it's minimal, so you can get the best of data. Otherwise, we lie to ourselves. Right. So on active antibiotics, what it means is we say by ATM they are acting on antibiotics. Those who by ATM in the morning are they given antibiotics, are on active antibiotics. Not those who are yet to or anything, not those who have been prepped for surgery and yet to. But if they've been given as ATM on the day you're taking the surgery, they are included. Those who are excluded, those who are not on antibiotics or yes, are being discharged. That is okay. And then I mentioned in the classification, I said that for systemic use only, so we only focus on medication that for systemic use, parenteral, rectal, inhaled, possible, and then oral, not topical. So you have no business going to a person cream because the patient on the ward was. Okay, understand? Okay. So pick the word form. We'll jump to the word form. This one. So it's on there. I have it on there. I hope today you can see you. Otherwise, we'll call the optician for you. So the date of the service. I said there's a point prevalence service. So one time, that date of the. This word form is for each word. each ward. That's why I was trying to picture what your ward looks like. So if this room, for instance, is female surgical ward, so this is how it looks like.
So, it's a very big word, but when you enter, we have the left wing, then we have the right wing. So the right wing is the medical, and the left wing is the surgical.
So it's L-shaped.
So you see, the other thing we could do is that, because how many of these classes are there?
Yeah, not structures, they are beds. So the left wing have to.
So the structure is all.
It's just a
Actually, the wall is
one structure, yes.
Wait, that's fine. So let's do this. So if the left is for surgery, right? And then as for maybe for male, then the same for female.
If it's male ward, it's male, medical and
Surgery,
surgical.
that's what I'm asking.
Female.
Yeah, female. Super. So what we'll do is that, what we'll do now is that if we go to female ward, for instance, and then left is for medical, that becomes adult medical ward. Right? One.
Yes.
Right? And we go to the male ward, the left side becomes adult medical ward 2. To make it easy for you.
Yes.
Yeah. And the right becomes surgery. So adult surgical ward.
One.
The same for pediatrics. So you see, I mean the same for, or however it is. I want you to understand the concept.
Yes.
However you want to do it. It's not, I can't decide for you how to do it. That's how I'm going to do that. Right. The survey, we call something activities. I mean, activity only means medical, surgery, or internal intensive care. So you see it on the form. If we went, that's it. So medical, surgery, intensive care. You need to define it because you are going to pick values. You see denominator and numerator. You are going to capture all the beds in the room, whether it's occupied or not. So if you have on the left, you have 20 beds. That goes into your denominator. So number of beds, 20. So if it's medicine, surgery, intensive care, you state those ones. There's a place where it can be a mixed ward. You see that on the form also. That means that, so there are some places that they have medical and surgical care. They say that's a mixed ward. Right. Whether it is by the circumstance or by design. Sometimes when there's a spillover, you move and so you identify. If you go and a patient is on the floor, you are capturing it, that's the bed. The protocols. If not the ones that have been discharged and couldn't be arrested, the ones that are having care on the air and so that becomes you assign a bed to them. So if it's 20 beds there and 12 months, that becomes then 2 beds. Right. So surgery or medical. When it comes to naming the wards, so when you see auditors are those who take the PPS on the team, a PPS team. So if it is 4 of us who are going as PPS, we are the auditors. So anybody's name can go inside there. I spoke about a web platform because I said I was born before 1928. You might think that I'm so old school that I like paper forms. I do like paper forms, but you see, when you have these problems, you can follow the paper forms. You agree? So don't try and go and do that. You can't even do it in the first place. So I always going to print paper and record on those ones. And when we have challenges, we can fall back and identify those things. That's how it's done. So then the word name, you can give the word name that you want. But you see the codes inside there. You can see adult pediatric. So PMW is pediatric medical, right? AMW is adult medical ward. There's adult surgical. So whatever specialty that word is, you assign it. You see, I said on the left, you can do AMW1. When you go to females, you can do AMW2. So that can happen. You can do a lot of those ones. So you note the code for the wards, but you need them on the patient when he gets there. So you note the codes on those wards. So whatever, if you have a separate ID ward for either adults or for pediatrics, you can write that. There's a place for OBGY also. You see that inside somewhere. Have you seen it?
Yeah.
Yeah, I see things I can see
It's
today.
It's done.
Your eyes are getting better than mine. I'm worried. So that's right. So in all the specialties that you can think of, there's NICU, there's PICO, there's an oncology department. You can add this for all those ones. So you are going to now decide how to allocate the wards. I think you also need to get a local administrator. That's a pharmacist anyway. So we're going to give an account to at least to coordinate these things for you. And they'll be able to put the liaison with us and PPS. That's the committee that Dr. Anna again will see to after that person. So you identify one person to be before the local admin. They will have the web interface. So what's it's not everybody going to take the data will have to do the entry. At least you can control the entry. That's why you should take the paper and be serious, because you might not be in the group that went to a certain place. So if there's no proper documentation and I'm validating on it, that you stress. Right. Okay. So we'll name the words like that, whatever you choose. We identify whether it's mixed or not mixed. So if it's easy, let's not be confused, because if you are deciding to use a left wing for medicine, the right wing for surgery, it means that it's not a mixed word. It's a mixed word if the left wing has both surgical and medical. It's only a mixed word where surgical and medical. So if you said the left was for, and also let's not go inside and realize that two beds in the left have been spilled over from surgery. So you want to count like this, that can bother you. So that if you assign left for medical and you go to the surgical bed, you identify that it's surgery. Right. Otherwise it will mix the things up. So we'll go. So I think we've done the forms part. Do you have any questions on the one forms? That's for the weight. If it's a unit, we record the stational weight and the weight. A unit. If it's not a unit, you go ahead. Then there's a gender. I've seen male and female. I don't know if you've seen more. But I've seen male and female, and then there's also like you. There's you. I don't know what kind of you is, but so that happens. Yes. So we're getting close to the data. The first is demographic. So what's the treatment based on? So you go into the folder, right? What's the balance now? 100% balance. Okay. You go into the folder, you have filled out the demographics. Now we're focusing on only antibiotics. So you see here, I should have mentioned, sorry, on the word form, you saw the that said number of beds. You saw that. So empty or not, if there are 20 beds inside there, 20 beds. The number of admitted patients on the numerator. Number of patients admitted, whether antibiotics or not. Right. Number of patients admitted, whether or not on antibiotics. So if you go there and there's someone who has DKA, you just count them. We will not include them in the survey. I will count them. Right. So that's for that one. Okay. So when you identify that, is the patient on antibiotics, you identify that. The decision for antibiotics, was it made based on biodata? Biomarker over there. So you state, is it a WBC, is it a CRP, whatever it is. You want to state that it is. So yes, what sample was it? Was it blood, urine, whatever? You state that also was for the on the form. Now if you state yes, that it was for use that biomarker, you state the value of the biomarker. So is it 8.36 times 10 raised to whatever you state obviously over there. Yeah. Oh. Yeah. The value of the unit. Right. This is so WBC or whatever it is, and then the sample, is it blood, urine, goes inside there. And then here is the value in the unit. And also, you see, you would realize, I think you would agree, that about 90+% of your treatment at all. Right? 100% initial is empirical. That's 100%. But essentially, about 90% of your. I'll be surprised if it was higher, and I'll be glad, because then if we said broad spectrum will feed its AMI, it means that if you are doing targeted treatment, that's an issue, right? I see that about the average across all the facilities. This I said is a point prevalence survey, so it's on that day. I'm saying that they would have requested cultures. They were not arrived by the time you were there. They might have arrived by the time you were there. So all those people, if you go and it's targeted, we'll see that. So was a culture taken to the lab? Yes or no? Whatever sample was taken, we whatsoever. You see, we encourage for prescribers to request the labs. Request it. So my facility, for instance, is supposed to be requested. Like when you are seeing on antibiotics on the ward, you request it. Patient might not be able to afford. It is beyond you. Whatever the reasons could be, it is beyond you. But as part of the change. Behavior change, one them to request it. Not to assume that they couldn't be or just in the plan the request for. And I've done one of these programs. I did a research on it where I audited the prescriptions in all the wards in the facility. And then to see whether the requested cultures would take it. You can see at the OBGY I was almost less than 25%. Because they're on protocols, right? CS, they will do a muscular metro. So those are blankets ones, but for other places, the address was very high. It was in the request, not in the actual comparison of the test. But it's it is good behavior, good practice to request the cultures, then leave for God to do the rest. Right? So if it's requested, you take yes, then you show us what sample was taken for the request. Now coming to the antibiotic treatment, you should see this in your plan. Like I said, you are looking at what has been documented. You don't assume anything. You don't go and say, oh, we wanted to write it or no. Just write what was documented. That way, when your results come, you can see what the gaps are. Right? You don't go and fix anything. You won't see who did it. The patient identifier is only for your reference on the thing. It's not captured inside the results. I'll prove that to you in the next presentation. So antibiotic name. Yeah, I know that's one. I'm only giving that from experience. I realized OBGY, especially because of how they do it. And then it is usually blanket. Those areas. Okay, it's yes or no. It's yes or no. The name of the antibiotic, amoxicillin. You don't need the brands over there because it's generic uses. When you meet things like combination amoxicillin, clavulins, ampicillin, sulbactam, or brasillin, all those ones. When you meet them, you are going to focus on the dose of the antibiotic agent. Clavulin is on antibiotic agent, just to help them. So is the sulbactam, or the sulbactam, and all those other ones. If it's a combination, ciprofloxacin is different. But if it is those ones, then you are going to capture the dose of the. So if it is 1 gram amoxicillin, you know that it's 875 milligrams. If it is 65, it's 500. If it's 1.2 grams, it's 1,000. So like that. That's how we capture this one. You capture the date of the. It's 500 to 600. You could initially, I remember once in the beginning, I submitted it, but then I realized that the data that came was skewed. If you write amoxicillin alone, it's going to add it to plain amoxicillin. We'll see the consumption. I'll show you the representation. Yes, I think I have it in the slides. So you see that over there that it will add it to it, but amoxicillin is going from amoxicillin, clavulanic acid. Those things are. So just record that one in the dosing, you just do the 75 dosing. So the start date. So today is July 31. So you can go into the patient started 2 weeks ago, antibiotic treatment. You're not going to capture what you finished. When you see switch to, it's not a business. So the patient started on IV KEF, 2 grams daily for an hour, then stopped, switched to. So what they are doing the day you are there is not a recording. That is active antibiotic, not the old one. Right. So that's what we have. So you see there are a lot of species there because you can go and the patients of so many antibiotics. Some KEF, gentamicin, so many. So then it gives you space for that. So the start date of that particular antibiotic, amoxicillin, what's the start date? Or 27 July or 18 July, whatever it is. Don't be surprised about how far, it depends on the condition.
So quick one. So if it's a combination like cipro and trinidad, you capture it.
Yeah, ciprofloxacin over there. And then it will make more sense when the data entry. And because we haven't started, we'll look somewhere. It's easier when we're doing it. So the dose, so you indicate 500, 200, whatever. Then the units, is it milligrams, is it kilograms, is it grams, is it tons, you just indicate those ones. Then the dose per day, 2 times a day, once a day, 4 times a day, whatever you indicate. Then the route of administration, is it parenteral, is it oral, is it rectal, is it even IM? Yeah. So that's for the routes. And we come to diagnosis. Look for appendix 2 for diagnosis. Yeah. You found it? captures the diagnosis, right? And then sometimes you might feel like the diagnosis you are looking for is not right. Just like the ICD-10, when you choose what is closest, is it? The same with this one also. So they've been coded. So instead of writing, or you don't write all of them, you just write the code for the diagnosis. You found appendix 2. Yeah, so if it was a CNS infection, any of them, that's a CNS. If it's I, you see the code I, ENT, if it's a lung infection, if it's a TB, if it's COVID-19. So skin and soft tissue infection are also captured. The different UTIs are also captured. You can see that these are the codings. That's the categories, these are the codings. Right. I also add that focus on this antibacterials now. For a start, don't enter the antifungals or antibiotics. Yeah, just focus on the antibiotics. Now that starts. Get a baseline. The baselines are not nice, but it's everywhere. The baselines are somewhere. Some of them are the actual issue on the ground. Some of them are the errors from voices. You know, so you do a SWOT analysis before you started AMS. Like, you do a SWOT analysis. You didn't do the AMS checklist or the IPS checklist. Okay, I mean, we'll fix. We're happy with it. So the codes are there. If it's unknown, it's unknown. And if there's no diagnosis, right? There's no diagnosis here. Or everything, no diagnosis. You see, it speaks more to quality of documentation. That is what we extrapolate to get a practice, the habits. If it's not there, it's not there. Right? If it's not documented, it's you don't have to even ask the doctor why they're doing the thing. It's not there. And that's all. So back to the form. So type of indication, is it hospital acquired, is it community acquired? Or is it prophylaxis, be it surgical prophylaxis, medical prophylaxis? Get to appendix 3, you see the code. Appendix. If there's a reason you want to do ascertain, then that's you want to spread out. From experience, only you have problems across concept and that limit. You have problems. That's recent. So what type of HAI is? I think I should mention that they say that the pathway to hell is paved by good intentions. Sometimes things end because of our good intentions or despite our good intentions. This is one of the issues we have. We only talk about in the implementation, talk about things like IVOS switch, IV switch, IV to our switch, because sometimes when you leave the line inside the patient for a long time, you open the vein for infection, catheter for infections, the tubes. Someone comes inside there for DK and they get aspiration pneumonia. It's from here. That is, it happens. So we have some HIs and infections, right? So the type of HI that it is, you can see that once you read the codings, you don't have to be coming to memory. You can just call on. So how can I apply it? You ask me, I tell you it. But they know it. Don't be honest. It's clearly there. Okay, I see many people, so I'm sure. Then there's a surgical prophylaxis. Is it 1 day surgical prophylaxis? Is it 2 days a day? Is it more than 1 day? Saying that's what I take you for 1 day, 2 months starts. Then you do maybe IV muscular how many times a day for 1 day? They can do for the surgery. Yeah, for kind there. And they can do the orals to continue. So whatever point you are at, then you record those ones. So it's coded. It's just to code. When you see it over there, the medical prophylaxis or other or unknown, completely unknown. I'm not sure.
So like options, like we are doing amoxicillin babalanic for 1 year, and we get there on the third day, they switch to orals. So are we saying it's surgical practice or we are like actually to feel like
So I like this particular case. Fast I mentioned so that he said it was switch.
what is the
So what's the other thing? Oral. That's surgical prophylaxis. We're giving antibiotics because they're selling the high.
yes.
Not because of it. Medical prophylaxis was SE. And that's it. That's medical prophylaxis, but then since it's called surgical prophylaxis. But it's more than 1 day, so it's necessary. Right?
Please, may I get a little clarity? You are asking because ideally surgical prophylaxis
This is just for a short period.
Ah.
So is it still surgical
That
prophylaxis?
is still surgical prophylaxis.
We are treating something, we are giving it for 5-7 days. So is it still prophylaxis?
But when after it's you give them the IV, you give them oral also. Yes, that's for 5 days.
But is it still prophylaxis?
If it's surgical prophylaxis after 48 hours, they should be stopped.
No, so but when they come from SVD, and you want to call it medical prophylaxis,
No,
So what name should we give it? What is oral?
SVM.
It's still
It's still SVM.
it's not a pass. So in your analysis, the point comes to you that is beyond the recommended.
That is to and like whatever helps you. If I do it, it helps focus. But keep it focused, yeah. So not so when some the residents departments the same way. So we're at reasoning notes, right? Usually in the educate, there's none. So there's a small, this one. I don't know what to call this one. It further explains all the small numbers that you can see. It gives you more clarity, so that when I'm not here, not a 9 is not here. I'll mention any numbers, so I can tell you what I'm. So also because the point is that she's promising you continuous support. Okay, reasoning notes, a diagnosis indication for the treatment recorded in the patient. I mean, you can see all those notes inside that. So if it's there, you'll assume it's there. I can assure you that some will not have it. I mean, it's everywhere, some. Yeah. So reason or not, yes, and the guideline compliance, where pharmacy is really important. So you went to the ward, you saw the case was pneumonia. There's a code for pneumonia, you see it. PNEU also here. The doctor prescription is tablets, oral, metronidazole, 400 milligrams 2 times a day for 5 days. So then you decide, is it appropriate for the patient, yes or no? So you indicate yes or no. Is it much we use as treatment for pneumonia? Maybe not. So then you record the no by there. So yes or no. So your reference is the STG. And if you're reporting, you want to state your reference as that's the STG. If you had Lechman has what they call the antibiotic man, antibiotic child. That's the pharmacy specific guideline from there. So if it was, they would have stated it inside the report. If I report, you go and claim that report here, you have stated it. Now let's stop or review it. Do they close the prescriptions here? Yeah. No, on the IV kept 2 grams for 2 days, for 3 days. They close it. It's not open. That's good. But as many things they did open. Some close, some do not close it. We're encouraging for them to close it. So I'll be sharing with you some experience. So a facility, like now for instance, we don't supply medication more than 24 hours. IV medications. That's an AMS decision. And in the subsequent slides, you see our leadership and all those things. So it's an instrument wherever you come from. They give you for only, even if the prescriber writes for 5 days, because the idea is to encourage periodic reviews. There's going to be a conversation from prescribers. Oh, some of the rates are not there, so we want you to supply, but we still insist on certain things. It's when you foster those relationships, well, no, EMS is not police. I mean, you can't be there and don't prescribe. That's what the plan, but it's to guide them to prescribe rationally. So some of those things will come. So my point is, even if the prescription is for 21 days, right? 21 days, close it. For what it's habit. So just close it. If it's not closed, it's open. So it means that there's no stop or review it. Documented. Every so if it's not, then you indicate it. The number of missed doses, you go there, you count the number of missed doses. That one might not, whether it's for fault or not, but then the point, we want to see what to amount to the missed doses. So that's where you can ask the nurse, oh, why they didn't have that medication? Oh, they haven't bought it. Oh, patients refused it. Whatever. So is the reason for the how is it here? So the reason for the mixed doses will be here. You see the code in this in your appendix in the document. So that was purchased, wasn't purchased, wasn't given, or declined. You just write the code in the simple. Now the type of treatment, targeted or empirical. I was saying that 100% of the treatment will start empirical because the labs will not be ready before sent to us, right? I think the other way, so in some of our conversations over the period, there's something you can give us before the actual purchase. Something is ready first.
Yeah, so preliminary results
are ready first before the it's how it's how your relationship is.
I think now the system that
Within 24 hours, the culture sensitivity.
yeah, so we are looking at that.
Nice.
Go for it.
Nice.
Yes.
Oh, come. When you guys let me know, so I'll join you. You have real pharmacists. So I have a case. I have a strong case. I'm reaching gender equality and social equality. Yes. So we're coming. We're joining US. So is there, so he said that we are going to get it with, but before that you start, the point is you are going to start treatments once you have enough reason as an infection, right? Whatever you use. Some people don't wait for the MDCs to come. So you can start the treatment. Then when the cultures come, you inform your decision. Continue, you discontinue. Let me ask the question. If the antibiotic you are starting is showing clinical improvement, but then your culture comes in and it's resistant, what do you do? Oh, you haven't seen that before? The results are showing resistance. And then you can see well, yeah, that's of course problems. I'm happy. So
what is the way to
with us,
is false positive.
you are talking to the integrity of the lab. But that's the quality of the results. It's a false positive. That's a fixed way. Oh, we've had to even do second payments in some facilities to see whether it works here. But we hope things are standard and people are certified. Yes, with SOPs, these things can be minimized there.
Well, the antibiotic this is right.
The quality of the test is so targeted or empirical. So at the point you went in, you are not you see, you are assessing the current treatment. So maybe the lab was like, oh, or the portrait there, but by the point you are doing your survey, the antibiotics being used are based on the empirical treatment. So it's empirical treatment. Like I'm saying, you see that over 95% of the treatment is empirical. Once I get targeted, it's exciting when you do get it. We used to get more at Phoenix and Nico. They are the ones that were, I think most of the work we focused a lot of things in Nico. You know, where leveraging their relationship with the various. You just start from somewhere, right? And when the success came, we were able to upskill to other departments. And also because antibiotic using is so high in pediatrics. So high. If you can, I don't know if you're able to aggregate your area data to check for pediatrics and adult treatments. So we're able to separate adults and pediatrics. You see that you're getting like 18% for pediatrics and then 12 or 14% for adults. Yeah. So okay, that's also possible. So when you identify that's targeted, should it be targeted if you continue on this one? That is where the microbiologists will come in. There's a form, I think I need to call it.
Sorry, I can be confused. There was something you said you don't do in PDS.
The ATCDD. Yes. I think I've been in form. So you can see the, I leave you for the target size. That is why that's a multidisciplinary. So we're done for any questions?
Yeah, I know it's with the inpatients, but that is not closed.
Yes.
But the outpatients, the one that is closed, is for the inpatients.
So that's how I'm saying that it's not only you, but you want them to do it.
The inpatients.
Yes. That's standard practice.
Yeah.
You need to close it. And sometimes this documentation, how do I say, incomplete, it fits into your peer review. Yes. You don't see that it scores 0 once. You don't score 0 value. You see? It's 10 or 0. One of the categories where it's other. So you see, so we know, we're all in the practice, so we understand what the challenge is. We know what's on the ground. But I hope that's this. But it would be nice if you score 10, because you want to few people score 10. I've done assessment at certain people. 0. The criteria says 10 or 0. So it's like name tags. If one person, if it's not denied, I don't work in the facility. I don't teach you, I didn't say that. You're not recording now. I take it back. So I mean, that's the issue. So you see, they don't close it, and it's known. You see, there was one time when I started talking about some of these mishaps, and then they wanted to defend us. But then later they realized that we were doing those things. And when you go to the water, you see these things. I'm happy it's like this. When you go, you see it. When you see and you want to make an intervention, you can pull out data and say, you people, data is showing that it's easier. Because it feels like you're accusing anybody if you say, oh, you don't understand. I pull it out. And if I share here that when when I started practicing, the exuberance and all those things, and then you go and the doctors don't. Back at this, we used to and feel the entire forms and the back. The prescribers will not feel it. And outside me, I don't feel it. I don't let my intense feel it. Now, I thought that, oh, you know what I did? I did two things anyway. The first thing is, if I complain about medication and recommend this, one clinical meeting and one, someone told me that, where's my evidence? I said, oh, I'll be nice. And I told them there that, oh, the next time I come here, I'll bring evidence. So I scanned prescriptions. Right? I cast the patient's name and I projected. So as I'm talking, you can see my eyes. So as I mentioned, I mean, it gets the work done because they want to see like evidence. Maybe you don't have, and this too helps you do those things. You identify the problem, you fix them. And then when you do the PPS again, you see that one place will improve. And sometimes the interesting part is that when you implement an intervention, it will work on the other side. It's not like you should expect that because we said don't park here. It's a good intervention. Maybe it saves traffic, but it also means that we have to walk a very long distance to which we won't want to do. So I mean, you find a way to fix it going forward, and how it works for you. Thank you. Let's go to OPD, then I'll show you the then we're done with that OPD. Let's go. Yes. So it's a similar thing. Look at OPD and IP. The dates of the survey will be there. The person taking the survey.
Sorry, the OPD one is it's
Oh,
a different set.
Sorry, I thought you could see it. Sorry.
Sorry, I had done them here. I found them here. One single sheet and then
The word form is similar to the patient one, but this one is a little different. And we've done it in different ways. So I'll share with you some of the exercises we have so that when you do it with them. I'm making progress. I have only two objectives to either confuse you or convince you. I'll do one by all means. So we'll start. So similar to the IPD form is one. You capture the person, the data. The same thing is one time. How many consulting rooms do you have? That's 8. Yeah. It's unlikely you can finish everything one day. You can do, yeah, so you can do several days. At the point when you go to room 1 today, you don't go to room 1 again. Unless it's a specialty that you want to include. Maybe you have a surgical OPD, OBGY, OPD, whichever one else you have. If you have neurology, all these ones. That's when the rooms are assigned for specific reasons. You have clinic there. I advise you avoid regular PSN. You could, maybe you should, but that becomes a little cumbersome. Maybe you should. You're allowed to do it anyhow. At least for the first one, get a baseline, then later we'll fix the rest. PS is specialist in. I don't know. Oh, sorry. Call it PS. So physician specialist. I went to government school. Sorry. I'm not with them. Sorry. So that happened. So it's also this one. Pharmacy does essentially. So when we use pharmacists, rather house officers, pharmacists, and then they collect for you. We're going to do it for at least 4 hours in a day. at a certain facility, they were taking the data retrospectively, as in they were in their, it's not very common, it's not very good data. So if you decide to go maybe today at 8 a.m., you go at 8 a.m., 8 to 12 is 4 hours, right? Or more, but at least 4 hours. What I advise is that the auditors will sit in the consulting room. It has to be as invisible as possible. It shouldn't be seen. You are not supposed to affect treatment. You will still will affect it anyway. It will be less than if you were asking. So you don't wear the red wig that day because you'll be seeing you plenty. From experience, that one facility. So I've seen their argument rate was about 40%, right? Right now what's the number? 23%. So theirs was like 70%. So because I've seen it, when we're doing the audit, as a recording,
Yes, please.
like small business. So one of my auditors said, one of the subscribers was saying that, hey, so I can't give my antibiotics because these people are here. Clearly, you know that's we work around it anyway. You find a way to make this protocol work in your like, space. So you don't affect it. So you want to listen as well as possible so you don't get to ask questions. They won't stop the patient because of you. They won't go back because of you. So you want to be there, you're listening. Maybe go on the checklist. Yeah? So the same thing when they choose the emergency, whatever it is, whatever specialty you want to do that, they just select it. Right? There's a day surgery for the number of doctors in the room. Some people have 2 doctors. I've seen places where you have 2, so the case each other. Okay. Wow. God will provide. I'm saying because so what means that they are seeing 2 patients concurrently.
Yeah.
Yeah, it's not about. I'm sure the pharmacy will find it. Find it. Because one person cannot be doing for the 2 patients. It will be very difficult. Is the room big enough to have people inside there? So these are the whatever clinic it is, ENT, I just choose and then you do for the day. So you do that particular room once a day. When I say room, I mean that particular specialty. So if it would help. I should have mentioned that the IPD, you don't do weekends and holidays. And I saw that when we did our SWOT analysis, we realized that how many senior staff are on weekends? True. And holidays. And weekends. Yes, when that happens, it gives you, it doesn't make it, it doesn't make it, you know what it does?
It's good.
Yeah. I think maybe sometime going forward, we should do specific audits for weekends. So, I mean, it's research so we can see where the gaps are because also let's open on weekends and nights. So, maybe we should consider also checking those areas. Yeah. So, for the weekend, nobody's there. Might be they're not coming back. So, the thing is not clearing from their eyes. See, we are all coming back. You know? And on Fridays, we either have funeral already in the weekend. You know how things change. So do those ones and you can get like quality. You see, it's a snapshot, but when you speak to a patient, so that's the practice. So what if the day you went to the survey, the doctors were all angry, for instance? You get the point? It doesn't mean that every day they're angry. Maybe that particular day, maybe their team lost or they lost the team. I mean, that happens though. Or they have someone who was harassed by people. So, number of doctors, number of nurses and pharmacists. So the pharmacy can leave it. Usually I just use the one that we have there because more assigned to each hospital. Like I said, there's a 2 designed by the EU in the UK. I mean, later the Brits joined it. So it might not be suited to, but we find a way to work around it and it works. So start time, you indicate and then you indicate closing time. Right. Let's move to the patient form. There are two patient forms. There's a short patient form, and there's the patient form itself. So page 1, when you select page 1, page 2 is the patient form. Are we there? So, in my advice, you start on the short patient form. This one captures all the patients, whether or not on antibiotics. We said about prevalence. You cannot calculate prevalence if you don't have the data calculation. Yeah. So, you have a reset, it makes your life should be easier. There was a time when I used to sit down, pick up you. Now, yeah, I mean, it's key everybody should reset it because it helps with some of these things. You collect and you for them, and what they do is they do it. So, the short form, when you start this one, everybody should go on it. So, when you enter the prison, the patient comes, you start recording the details, right? And then when there's a need for antibiotics, you switch. You see, if you have this form and you're waiting for the patient, for the doctor to say, oh, antibiotics, you'll be in trouble. I don't know if you understand. You miss it. Because if you don't have antibiotics, what do? You start from here. And you can see, so it asks for the patient ID, that's the GIMS number for your referencing. Survey number will be given to when you save that transaction. The gender, sex, male, female, unknown, right? Then the age, the brackets are there. Now, the presenting complaints, the symptoms are, do you have temperature? Is the temperature high? You take it. Do you have, are they nauseous? Is there seizures? Is there diarrhea? All those things you take it. You can see all those things. So you do for every patient. So if then whether labs were ordered, that one to you show. Whether the patient is already admitted, is going to be admitted, or is coming from home, you indicate all those ones. You can see from there. So when you do this, and it gets to where the doctor says, oh, antibiotics, you can just jump over here and continue with antibiotics. That way, you'd have got this data, this one and this one. Yeah. You see. Then later you can just cross out that one. So in the later entry, it's easy for you. You follow? So you start over here, you feel that you hear antibiotic, they say, oh, antibiotic, and I move, then I continue here. Because if you are waiting for that, you miss out on the of antibiotics, or you waste a lot of this form. Right? So from there, there's a similar thing we have with the OPD. Cultures taken, yes or no, you indicate what type of culture, when it was taken, before or after. You know, you encourage them to take the cultures, to take the samples before the antibiotic treatment starts again. And so, the same thing, it informs what's happening on the ground. Treatment based on biomarker, we saw it in the earlier one, right? Whether it's a CRP, a WBC, whatever it is, you indicate. When you indicate, yeah, that's fine. The value of whatever it is for the units, like the IB indicates. Do they have underlying conditions? Are they hypertensive? Are they diabetic? Are they immunocompromised? Whatever it is, you indicate that also. Then the treatment. So the name of the antibiotic, we spoke about that. Then when it was prescribed, you see things like ongoing and switched and all these things. You can be in the consulting room that time, and someone who came to do labs 3 days ago is bringing the labs for review. They qualify. So the decision on the antibiotics is based on that one, you indicate it. It will also be that you are there and the person has to do the labs. You don't follow them to go and ask them once that they go. You don't capture that one. So those also join in, you just continue. So like I said, no intervention, you don't have to go and look for the answers. Whatever you get where you are is enough. Right. So that's an ongoing treatment or whatever is indicated. Now the dose, the units, the frequency is the same for the IPD. The only difference is the guideline compliance is more detailed than in the IPD. In the IPD, is it compliance, yes or no, you end is there. You don't ask whether the frequency is correct, the dose is correct, the duration is correct. Even the route of administration, whether is correct. I don't think you have practical solutions for pneumonia at least as practical. But we're open to learning every day. So if you saw something topical for pneumonia, let's say not compliant. Right. Let's know that doesn't the protocol covers for a mixed infection. Right. So you see the number of antibiotics. So classical example is someone has a diabetic foot ulcer. So that goes into SST, right? Skin and soft tissue. So and then someone has and so you see if you do the amoxicillin for the pneumonia, what they are doing pneumonia indication C1, CI or HI, whatever it is. Then you come clindamycin. You have done clindamycin, whatever, SST, because that's for the skin infection. So that there's room for those things. It's not that you got to choose pneumonia for that, all the antibiotics that for pneumonia, because you have been doing medicine, so that covers 4. So you can get surgical prophylaxis somewhere and get community-acquired infection somewhere on the same patients, but on the respective antibiotic. Right. Okay. So when it comes to the compliance, so type of indication is the same from the IPD. You see, reference guidelines, is it local, is it Wales and no? STGs will be local unless in the plan it says that there is some particular guideline that is not STG. That's also about necessary proper. Then is a drug of choice. Is it compliance with the right? I don't think we'll see typhoid and then we'll be expecting them to be using amoxicillin. Like it's a bad choice from the beginning. And my colleagues come and talk about the selection issue. Not selection from here, selection even from the from the procurement and poor selection. It affects access and all those things as well. The dose, is it correct? Is it the proper? Is it under dose? Is it 1 rounds 1 time? And then the pharmacist. I mean, for us was learning. Was learning something that was rounds. Yeah, rounds there. And let's see how they did it there. So the pharmacist there was given a particular dose of antibiotics. And what they have on the shelf is what the person can have. I'm like, even if that's what you have on the shelf, even if it is the suspension you have as a pharmacist, I'm able to do. And I use simple ratios to show them. But of course, I'm from Ghana. I didn't go there to tell them what to do. I only told them. But the point is that that's how much capacity we have here as Ghanaians. That's the person was going on. That's in the rounds was okay by everybody. But I'm like, no, you can't do that because of the waiting. I took a pen and I just wrote, no calculate, that's it. We just did it. But then, so those things happen, and I lose it. Example, my thing that's right. You see, the feature we're doing is when you flip the PBS and you benchmark, you can compare to see what is happening in Europe, what you're doing here, and then you keep it. So that people will think that to be trained in Ghana is not quality training, it's flawed. I'm not speaking against, I'm just showing that there should be some confidence in the practice of doing it. We might have logistics problems, but I don't think that our knowledge is great. So these things help you to identify those things. The duration. You see typhoid or pyelonephritis is for 5 days. I mean, if you question why it's for a very short period, you're expecting it to be 21 days, pyelonephritis, or maybe 24 days. Even H. pylori, I have a big challenge with that treatment where there's so many conversations with an antigen test which is there. Right now they're saying that use endoscopy to confirm diagnosis. I mean, we cannot, me anyway, but that's the point. It's not just expensive, it's quite basic for H. pylori. So prescribers are going, so if you look keenly at your REM data, I've done budgets for some few places. You see that H. pylori was high. So right now the other part was that the conversation is why don't we invest whether so from AMS one it leads to the next one. You realize you are specifically addressing the problem. So the lab wants to do some research with the isolates. When it opens up to these things, that's the fun part about it. There's more work, documentation. They are talking about reporting. You'll be reporting right now. So if you're not doing it before, ask the following one. But then there's so much you want inside these things. Then the rules. I mentioned that I won't see topical for certain conditions. So that's what's there. Is that 5 minutes? What are the results look like? When you finish the platform, here you can do the survey. So you can do at least 3. Nothing more than that. We got January, May, August, as possible because you can't speak entirely one survey. Right, as a point of balance survey. If they multiple times, you see trends, and then that should do it. So when you upload, you validate. When you validate and you upload, and you request the feedback, this counts. So whenever the local admin is, you get this one. You can download or it can be sent to you by mail. Like I said, you control the data essentially. Whatever you put into this one, you have access to it. If anybody wants to use it, then they have to get you to have access to it. Right. So this is what I mean. So this is everybody who is involved in the collection. This is 2023, so I'm sure by now more facilities, more countries are involved in the survey. This is English. Okay. You can see how it is overall. We'll just focus on where I find rather important. This speaks to prevalence. So those are the word names that the word types that were there. You know, whatever possible. This is a dummy. This is a dummy for us to a sample for us to work with. Patient for the particular facility. So if it's here, it's our hospital. And the lights. Try it. So if you make errors with the documentation, you might be saying things like 100% prevalence, correct, more prevalence data. We come to consumption. So we'll do this for you, right? You see how much you are using. So the color codings. This is penicillin. This is other beta lactams. That is sulfonamides. Yes, how your eyes. No one's doing the colors, no one's government school. I don't know those equates and burgundy. I don't know those ones. Yellow, red, and blue, those ones. Right, but that's consumption. So you see which one is highly used, a beta lactam, so the cephalosporins. So the IV 2 grams start with the inside this one. A lot, caprodoxin, cefroxime, all these ones like cafotaxin, we use that here for pediatrics. So that would have been inside here. And very easily you see a lot of consumption for penicillins and other beta lactams. Because even your standard treatment guidelines, essentially, what the first times are all these ones here. So it gives you this one also to speak to. If you did it today and then it was high, I mean, you can able to tell. As the DDD we're talking about, we cannot dodge it. It's a new something, the new entity. So we've seen a lot of it. So it gives you the consumption according to the types. So you can see penicillins, beta lactams. You can see, so you can see, it gives you the exact consumption across. Like percentage of your consumption, not like globally. So your consumption. So and I think in Africa, you know, so we'll see that essentially maybe 8.6%. This is just theoretical, just actual values. It's not right. But I said 8.6% is that penetrates to extended spectrum. Or you can even pick some macro light, 5.2% in the consumption. So we see those things. There's more on the proportion of antibiotic use. Use also because it's the dispensing, I mean, that's the patient data. You have been from the first presentation. It's used because of patient level data, right? Because what you are collecting is the patient level data. More consumption. Yes. Now the fun part. I mean, this is one of the best parts of the NDK. So everything you were doing inside there, you can see percentages according to the activities: medical, surgical, ICU. This is not just for internal medicine, so all the medical pediatrics would have gone into surgical to so it's activity, not the just necessary. So you see that this is the number of patients that had the reasoning notes, about 95%. You won't get 100%, but you can try to get close to 100. You could get 100% for things like this one, 1 and 2. This is always a challenge. I don't know why. That's it, they don't close it. So we're going to know. Yeah, so you can see guidelines 50% from the data so you can speak to. So the first one, and then I remember one facility, the first guideline compliance was about 12%. And you see, you are the ones assessing it, so you are the reference. This is from right. And the second one went about 78%. Then it went about 80%. Then it dropped to 60-something%. But it's very easy if we assume that because you are starting and the teachers that's a flawed that's a flawed plan. Sometimes they will dip somewhere. So either show complacency or you can explain the right train class officers because you want to come. You have to train. So this helps you to do those ones. So you can see for surgical and also. So I did a similar thing in the audits for all the departments. So to see that medical ward is what you're doing. And then there was the in charges, the doctors in charges, they were the ones going to defend some of these things. But then they understood, they go back and they thought that people are home. Later I see that people are not recording your stock of units. So very quickly, continue. So he breaks it down into adults, neonatal, but then I did a summary, so we can go quickly. So your most used antibiotics, you see those ones also from the survey. You will see the top maybe 5 or 10 diagnosis. You see. So duration for surgical prophylaxis. You see we're doing the all measure all those things for us. Then we can compare, keep comparing against Europe, against the Pacific side, country or continent. So it separates it. There's even IV therapy. It's like I said, it's a very detailed. So whatever you want to speak to, that your reports can be maybe 30 pages. Depends on the area you want to speak to. So I mean, you can decide to report on. So it continues. So empirical assessment. That want you to identify. So you're able to see. But really, about 90%, like I said, is empirical. You represent about 74%. But that's analysis. And the microbe data is also there for the type of organisms that culture. I wanted to mention the healthcare acquired infections. There's a model for it. But because it's your first, I wanted to focus on the basic one. So in doing your first survey, focus on the basic. Start and see what it looks like, and then you can go on to the HAIs. But even this one, you'll be able to get your HAI rates from it, because some of your medication types are HAI. Different, so you see maybe 2%, HAI, 13%, whatever it is. And when you do it continuously, you see whether you're making progress or not. Because I think there's something about SSTs at surgery or OBGY, surgical site infection. There's a QI project on those things, so we're able to measure some of these things even inside the other PPS. I want us to get to our classification. So they will do the classification for you. They will do the from the consumption, we can see your progress in our classification. I think I mentioned that the target for access consumption globally is 70%, this with 30%. So we're hoping that globally we'll consume 70%. In our consumption, 70% will come from access groups, because we agree that they had the least chance of resistance as compared to the other ones. So it was 60, now it's 70. So people are in Ghana, we do, I think, 58 to 62% we're getting that, but now it's increased in a new action plan. So you're able to see it, you're able to advise at pharmacy, because it will show you this one, right? So it's able to also, it can transfer it for you to medical, surgical, and then ICU, more consumption. Your most used antibiotics and the percentages. The protocol does everything for you. And then you can report where necessary. Okay, so we skipped the HAI, so I won't say anything about the HAI. Thank you.
I think we've been sitting too long, so we want to stretch a little bit. We are not stepping out to, we are doing it right. So we will have none of us to do that.
Enter the ball, talk to the ball, carry the ball into the hole, under the hole.
Today we are going to spell antimicrobial. When you start with A, then you continue. When you see the one, she is going to miss it. Antimicrobial. So everybody must be attentive to know the letter he or she is going to have. This is not your sitting place. Okay. So antimicrobial. A.
N T
M.
No, that is we are going to school.
You said M.
He is not at. He is not at.
Oh, but we are all doing.
He is not at. So let's start.
Let's start.
A.
N T
I. M.
She is also not bad. The two of them. That's why they are finished. So where are we? M I.
C. I was just mentioning
O.
B.
I.
O.
Yeah. I.
A.
L.
L.
Okay. The next one. So we have to stretch. So we have to stretch. Yesterday we did the ball. Today we are not doing the ball.
Oh.
So we are going to do. I think all of us when we go to primary school, there was one rhyme. My head, my shoulders, my knees. But this one we are not going to sing the song. So if it's head. If it's shoulder, you maintain shoulder. We are going to see those who are going to miss the task. So the first is head, shoulder, knee, toes, knee, shoulder, head, toes. Okay.
That would be our point too.
These people's ways, they will be better.
Good afternoon to you all. Apologies, I've had to take some of these notes, so I will get these ones done. But hopefully now, once we are done, we'll go back to the model 6. I'm hoping that we'll be very quick about it. Shai Osu, okay? It's too small. Too small. You are in the spirit to me. So there is a drill answer, and I'm taking you through the clinical guidelines basically, and then the clinical setting that might be our stewardship. Most of what I'm going to talk about, I believe we've been exposed to a bit vaccine. I need to find out, are we all DTC members? So this is the DTC being trained.
Yes.
the nurses? You are not a nurse. One.
Yes.
Any other?
She is.
Public health.
Yes.
Health assurance.
Okay. We're looking at adherence to treatment guidelines and protocols, which is why I asked what the prescribers here are, because it relates to them. But then it also relates to all the pharmacists, even with the lab team as well. Lab team, anyone from lab team? Just a lot.
No, he said HI.
Okay, I hope they will step in before I finish. Okay, so basically this is what we're going to cover. We are looking at the roles of guidelines. How many of us have access to the current standard treatment guidelines? You do. Do you have one? The current one. Yes, the current one. The most recent one. The 2026 one. You don't have those. You don't have those. So which one do you have?
The old one.
Which year? 2012.
Yes.
And the 2017.
It's 2017.
The
The
2017.
most recent.
2017.
This was the 2017. The 2017. Yeah, that's the first. Yes. 2017. What is the point of having a standard treatment guideline? Why is it needed? Let's think about it. Why do you even need a guideline in the first place? In practice, pharmacy, lab, HIO. Why do you need a guideline in your practice? Yes, madam.
For uniform practice.
For uniformity in our practice. For uniformity in our practice. HIO, any important things are there?
As she said, it's for uniformity across the board. So whatever I do in Shai Osu Doku should not be different from whatever someone at Bolga Municipal Hospital does. So at every point in time, if assuming I find myself in their environment, I should be able to fit in as quickly as possible.
Okay. So thank you. Yes?
Also to have something we measure our practice to measure ourselves to know how we are faring,
Okay.
that we are doing the right thing.
Okay. So it serves as a standard to which you measure and assess your practice to see whether it measures up or not. Okay. You want to say that?
No, I want to say that if any issue out of that can be a whole case and affect the prescriber. It's serious.
Yeah, it's a serious document because basically that's what we measure everybody to. So if there's an issue, that's the standard we are going to take. Okay, and then assess you by. So we want to look at how hospitals play a critical role in antimicrobial resistance problem. We look at the institutional interventions that drive rational antimicrobial use at the facility level. We look at what the treatment and clinical practice guidelines are, or how we expect them to be. If you want to attend to post, there are posts. We look at the role of treatment guidelines. We look at the role of treatment guidelines in microbial optimization. We look at some examples, what pertains locally, what pertains internationally. Okay. So how do hospitals form a critical component of our antimicrobial resistance program? Let's look. How do you think we are contributing as a facility to antimicrobial resistance program? How does healthcare contribute to antimicrobial resistance? What are some of the things we do? Or what are some of the unique things about health facilities that may antimicrobial resistance? When the teacher please that pop on the that's the question. question, then use one eye, use one eye. So any office, what do you think? Yes, it's true. No, you're right. Just it. You're right. Right, just it.
Non-adherence to IPC protocols.
Non-adherence to infection prevention control protocols. Okay. Simple non-adherence to IPC. Okay. If you are not adhering to IPC, what will happen? You are going to spread the infection, isn't it? So you are going to use more antibiotics. What else? Chief, you have the overdose or underdose. Again, this is in the health setting, healthcare setting. So again, we increase likelihood of resistance. When we use them inappropriately for the wrong reasons, again, we stand the risk. So you realize that when you take health, we have very okay, they contribute. Okay. When you are likely to find patients, it's in the hospital. You can't find it in somebody's room. That's a great old church. So you see, but I said in the hospital. So very ill patient, we undertake a lot of invasive procedures. Okay? It's only in health facilities that we go invasive. We have a lot of prescribing, true or false. Our pharmacists, what do you see? Our prescribers, what do you do? A lot of broad spectrum prescribing, and then person-to-person contacts. When you go to the wards, what do you see? When you go to the outpatient settings, what do you see? Okay? Again, someone will say, oh, in the market, but there is more person-to-person contacts. But these are well patients. Okay, how many of us go to hospital because we are well and we just want to go see the environment? So that's it. Okay, and with the sick, we have quite a lot of person-to-person contact. So if you don't have good governance system in our health facilities, we are only going to end up spreading infections, increasing the risk of antimicrobial resistance facilities. And it says that in the health setting, generates a lot of resistant organisms because they are practices. Okay, and we move them into the community. I remember I visited one of my relatives was rushed in there, but post-CVA was not feeding. After a few IV drips, it was okay. Day 2 on oral antibiotics, nothing else. Day 3, I started discharging. Discharging, but the longer she stays, the more likely she's going to take something else. If you are not giving anything parental, let them go home. Okay, because that was what I had in mind. So we have a lot of resistance strains we go in the house and we move them to the community. Spread it amongst the community, they come back to us. Okay, probably even in the West States. So there are a number of activities we are active. That increases the risk of generating antimicrobials. Our selective prescribing. Often very empirical. Okay, that's coming. Okay. So we see an organism and then we prescribe a general or a broad spectrum antibiotic. Okay. That will increase the risk of resistance. Cross transmission pathways. Again, the shared space in the healthcare setting. Okay. The close interactions amongst patients. Again, is likely to spread resistant organisms because we touch in the healthcare setting. We touch a lot of patient environments. And that's as we said earlier, IPC is almost nil. And then the number of high-risk patients we see, a lot of immunocompromised patients. Okay. A lot of immunocompromised patients. So all this makes the healthcare setting a high breeding ground for antimicrobial resistance to. Shows the burden. I'm blocking your camera. No. I'll find the phone. I this shows the burden we have. Okay. Currently, the estimate is about 1.27 million deaths as a result of this antimicrobial resistance burden each year. 1.27. And if you are not careful, by 2050, we'll be hitting somewhere 10 million. Okay, I don't think anybody wants to go there or get there. Okay. And you may think it may never be until you fall sick. Okay, and you find yourself on admission somewhere and you realize you are powerless. You are powerless when you are sick. You can't take a decision for somebody takes that decision. That person makes a mistake and you end up as a statistics. So we need to do something about it. Now, the targets are set for the 2026 the gap analysis shows that we should be doing at least 70% of the access medicines. Okay. But we may not, we are even struggling to reach 60. So we may not be able to even achieve that if you are not careful. So there's a lot of work we need to do. Because even though these access medicines have less likelihood of resistance, they cannot be knocked out. And we'll have more of them becoming resistant along the line. If we are antimicrobial stewardship, we have more and more of our medicines becoming resistant. So what are some of the interventions at the facility level? Let me take this back. At the facility level, what are some of the things we can do to prevent antimicrobial resistance? We started with the problems. We are not the solutions for what you've already said. IPC practices. IPC practices. What else can we do? That's practice or not? Are we not? It's not Shai Osu Doku hospital. I'm talking about how you actually see. It's not a peer review answer. How the proper answer? You think we are here to practices?
Examine the next patient. At least once you examine the patient, you have to. Before you go to the next patient.
It's very important. There are times when I enter a ward and I see somebody in gloves, that's when I even get scared. Because the one in gloves touches everything that's okay. Because for them, their gloves, they are protected. They'll touch every surface and come and touch this patient, and go and touch this and come and touch this and that patient. Forgetting that they need to change between patients. Okay. So IPC practices, what else?
The protocols. Having standard protocols.
Having standard protocols and guidelines to guide our practices. What else? Having the standard guidelines and adhering to the protocols, adhering to them. What else? What else can we do? Are we doing? We have to. So national use of antibiotics. National use of antibiotics.
Because it will.
Straight. It works.
Even 30% if the body can
You should use rational use of antibiotics. What else? What else? Chief, you said we should go by which you mean?
ETCAMS.
What else are we doing?
Yes, we spoke about the antibiotics. So having particular diseases with particular antibiotic sensitivity.
So having antibiotics. What else?
Make sure our labs can be formed.
Sure, labs are working and they're able to do the cultures, isn't it? What else?
You have to also ensure adequate surveillance.
Adequate surveillance. What else?
Limited staffing. staff.
Continue training and retraining the refresher training. What else?
Proper disposal.
Proper disposal of antibiotics that are not used. Yes. What else?
Research.
What else? Proper segregation. What else? Please, what else? You look too simple, eh? I was waiting for one Okay, so yes, there are some interventions we put in place at the institutional level. That will reduce the resistance. Okay. Those driving those interventions, and the hospital therapeutics committee. But most of the interventions will be driven by this team. Yes, we have infection prevention and control. We have a IPC focal person in this team.
Yes.
Okay. Then we have the DTC members itself. Institutional formula, who develops them?
DTC.
DTC. It's not part of DTC.
Yes.
Who does antimicrobial stewardship? Please. Whatever team is needed,
DTC.
DTC. Okay. And clinicians part of the DTC.
Yes.
You see, so if you have a very strong, robust DTC, a lot of these challenges against air mouse will be solved. Okay. So you find yourself in a very powerful position to help others. So infection prevention and control. And you will recite it every time, especially when it's close to peer review. Hand hygiene compliance. Okay, how well are we adhering to this? Okay, how well are we adhering to this? So I was on a virtual meeting yesterday evening. One foreigner who came to do some peace corps something in Ghana goes to Data General. That he has read how do you call it? IPC guidelines, that book, Ministry of Health, that big book, he has read it. I realized that as an institution, we do not adhere to the use of respirators. Because in all the facilities he listed, he never saw anybody do the fit test. And for him, that's all he has picked up. And he's written 2 pages for the Director General, telling him we don't adhere to our own guidelines, and therefore he wants to help us build capacity. Okay. I believe you all know the fit test. You wear the N95 mask, okay, and you make sure it's a good fit. Because when you pick some of the masks, let 5 people wear the mask. For somebody, you see space all around. For others, you have a good fit. Yeah. So again, there are various sizes, and it should be tailored to the size. The same way you take gloves, you have size 7, 7.5, 8. Everybody wears their own size. The same thing with the mask. But they realize that when you come to a facility, it's one mask fits all. Okay. So really, you are wearing the mask, but there's space all around the mask. So beyond hand hygiene, when you come to isolation, contact droplets, airborne precautions, then those filters come in. Okay, especially for droplets and airborne precautions. Are we giving masks when it's needed to our staff? Are we giving the N95 masks and other respirators to our staff when they are going to areas where these special precautions are? Our several systems for hospital are different. How strong the robust is it? Are we undertaking several? Are we sitting, is somebody sitting in this room and inputting data, or we are actually getting data from the ground? Because last time we had a meeting with the regional directors, one thing that came up was that sexual site infection, there's really no specific protocol or definition that cuts across. So they wanted to know what is actually being reported in DIMS and how we are getting data in DIMS. But I'm sure this is more okay, so how are we undertaking several for hospital-acquired infections? Environmental cleaning. This hospital will be very good. How are we ensuring the environment is kept clean? Which agents are we using? Are we just using water? Or we are using agents that will ensure that the environment is, or especially patients' environment, is clean of, is rid of microbes. So those are some of the issues we need to look at, and infection prevention and control. Okay. And it's not just the IPC focal activities. It's a whole team's work that the DTC needs to keep an eye on. Of course, the hospital therapists committee have their own unique role. Their formularies that your surveillance reports. Has there been any contact, any surveillance reports that DTC has looked at? DTC, have you looked at any surveillance reports? Okay, the answer. Adverse drug reactions. Has it been discussed in your meetings?
Yes.
Okay. Your antibiogram data, do you look at them? Do you do any study? Have you done any study at personally?
Yes, we are on it.
You are on it.
Yes.
Your work plans and targets for antimicrobial stewardship. Do you have an antimicrobial stewardship?
Yes.
You know the entity. Okay. And of course, has there been any training on antimicrobial stewardship for prescribers?
Yes.
Yes, when?
We done 3 trainings.
This year.
We did 2 last year, we done 1 this year.
2 last year, 1 this year. Okay, there are clear rules for you. And it's important that at the end of the year, you try to ensure that you are undertaking all these activities. They have your institutional formularies. Are they evidence-based? Do you have an institutional formulary? How was it derived?
We use the STGs.
So it was derived from the STGs?
Yes.
Okay.
And the current updates from the various lines. So we just took 10 diseases at the OPD. Then from those conditions, we will see the guidelines on it and the treatments that are supposed to come with it. So we killed it from the STG and the current changes in the prescription.
So what's the number of evidence?
So now we'll also strengthen it with the
So you
antibiotics.
strengthen the
Yes.
Are they aware aligned restrictions? Okay, I've heard you talk about it already, so I'm sure you know exactly what you are talking about. The medicines we use. I say access for what?
Most of them are access and watch.
I'm on different laboratories. Access for what? I'm on different laboratories. What is it? Is it traumatizing? Which group?
It's not broad spectrum. Watch is broad spectrum.
I'm on
Access is narrow spectrum.
So among different laboratories, which is it? azithromycin. These are what you guys are.
Yes.
Don't you?
Yes.
I'm sure today, before you came here, you looked like it. Your formulary have any indicate that this is association. If this is
Yes.
okay. So those are all important as we draw up these documents. So I just pull this up, okay, for us to see. Amoxicillin clavulanate, which group does it belong to? Access, okay, access group, okay. So it's supposed to be a basic narrow spectrum and focus, less resistance. Chloride. Have we raised them like what time? I don't remember the last time I even prescribed Zinacef. Because I've lost trust in Zinacef. I've lost trust. All the chloride, I've lost trust in them. Because when I was in graduation, 2015, 16, that's when I decided that, look, it's not working for us. And I stopped writing them.
Okay.
But these are watch groups. Captrazone. What? Attempts to COVID. Right now, if you, there was a point I go on work rounds in my emergency, then there is, and I get annoyed because almost everybody's on Captrazone. Community applying pneumonia, Captrazone. UTI, Captrazone. Everybody's on Captrazone. And yet, it's a watch medicine to be regulated. Capitalism, again, now they do. Give a start dose of Captrazone and then continue with the and that's the what we are doing. So you go to a health facilities and realize that most of the medicine that is azithromycin, again, thanks to COVID. And anybody can even walk to a pharmacy and request for azithromycin. And to begin with, that is what you do. So it tells you how much we are abusing antibiotics. You have a runny nose, you cough once, twice, you want a pharmacy, it's azithromycin. Strict. So that's how bad the situation is. So if you are not strong on your formula and insist and supervise and make sure we follow it, you are going to have all resistance in all this because all these watch medicines are prone to resistance. Broad spectrum is prone to resistance. So we need to watch this. Then our lab. Okay. Our lab. Any management member here? Okay. So again, it's important that we strengthen the lab as well. And be able to do culture sensitivity testing. Because it's important for us. Because if we send all our culture sensitivity outside, we are not going to get it to analyze in our facility. We want to know what is happening in our own facility. So culture sensitivity testing, facility antivirals, okay? Any outbreak detection, they are picking certain organisms frequently. They know there may be a pattern, something is happening. Okay, and then of course, standards. If we are able to get our results early, the results are to de-escalate. So they can give us initial reports that guys are caring. It helps. So again, we need to strengthen our laboratory services. It's one of the strong pillars that we have. Of course, antimicrobial stewardship. Is any one here who belongs to the team? You do. Oh, great. So when was the last time you conducted a prospective audit? Okay, has answered
Actually, I think that's one of the details.
So again, it's important. You need to review prescriptions and provide real-time, non-predictive feedback to prescribers.
We do that all the time.
Okay, which is great. Okay. Prior authorization medicine, I don't think we do that. Anyway, you prescribe free range, or you do?
We do.
So how do you go about it?
So we usually go through the wards and the ERs, and we check the diagnosis and the medications that are given, and we go back to the prescribers and talk to them. For instance, we had a situation at Ops and Dining where they were using Keftrag. We said yesterday, as I said, post-surgery, they give to Keftrag. And that was our observation. So after we had our meeting, we had a smaller meeting with them. And as I now use our mox and craft so they were giving it pre-surgery and post-surgery.
So clearly, the center is only a senior person who can prescribe, authorized for his prescription. Okay, so that they know that you don't just come a house officer, etc., prescribing because you think you can do that. Then, of course, prescriber education. So, that's my program stewardship has a lot to do. And then last but not the least is the use of treatment guidelines. The use of our treatment guidelines. So we've spoken about 6 good interventions that at the facility level we can implement to help reduce antimicrobial resistance. Let's go through any of them. Can we take this? Anyone? The ICC, strong nutritional formularies,
Guidelines and protocols.
guidelines to be for removing chapter 1.
Strong microbiology.
Okay. So we are ending with the clinical guidelines. So basically we've spoken about IPC, drugs and therapeutic committee, formulary now, antimicrobial stewardship and the guidelines. And these are all linked. None of them sits in isolation. Okay. One affects the other. Okay. Laboratory data can inform what you put in your guidelines. Okay. If the lab says in your facility, this organism seems to be resistant to this antibiotic out of your guidelines. Your DTC will enforce your formulary. Antimicrobial stewardship audits will help in adherence to guidelines. What are your prescribers doing? Are they adhering or not? They need to inform you. IPC will reduce the burden of infections you need to fight against. Okay. So they are all linked. So as a team, these are 6 key areas you should be interested in. Okay, so you don't just look at antimicrobial stewardship, but you should be interested in this. You should know what is happening in the lab and how strong the lab is. And then of course your formulary. How is it informed? How is it drawn up? What are the evidence-based things? Your DTC and then IPC issues. Now when it comes to guidelines, clinical guidelines, what are they? They said that they are the standards we aspire to achieve. Okay, they are more or less standards. So basically, guidelines will tend to recommend what should be done. Who should do it, when it should be done, and how it should be done. So it translates best available evidence into clear actionable recommendations. It picks evidence from several places, puts it together and say, for this condition, this is the best way it should be managed. A standardized diagnosis, investigations, and treatment decisions across prescribers. So for this condition, once you mention malaria, okay, HIV, how do you diagnose malaria?
First, we have to look at the clinical signs and symptoms.
Clinical signs and symptoms?
And support it with laboratory investigation,
Okay.
whether RBT or microscopy.
Okay, and
then once the condition...
and you learned this in HIO school?
partly there, and then on the job.
Because again, there are standards. Okay, so once you pick the standard, everybody knows exactly how it should be done. Okay, there are clear guidelines on it, on how things should be done. So it's important that it standardizes. Again, it specifies first, second, and alternate line antimicrobial choices by indication. So for every condition, it tells us this is what you use. If you cannot use this, this is what you use. Again, that is also to prevent resistance from developing. Okay, so now what I do in facility A is the same thing as in facility B. Okay, and it can be applied at every level of care. Kolebu doesn't treat malaria different from a Kuma chips. The same medicine is what will be used. Of course, Kolebu will be paid more for whatever reason I don't know for the same malaria. Okay, but the treatment is the same. The investigations are the same. Okay, so it can be applied. So when we have standard guideline, the standard treatment guideline we have now is the same document at the chief's level. It's the same document at the health center. It's the same document at the hospital. It's the same document at the hospital. It's not different. Okay, but you pick your level and what you can do and you apply it. So typically a standard guideline, and here I'm not just talking to the clinicians, even for the pharmacists. Don't have standard guidelines for this. Yes, so across HR, you have a standard guideline who specifies your definitions and how you do your entries.
Yes.
It's a standard guideline. So HIO in Shai Osu Doku will not do it differently, do entries and define its denominators differently. So the guidelines cast across. Okay. So for the clinical setting, there's always a diagnostic criteria. Okay. And even though it's an HIO, he said it beautifully. Signs, symptoms, and tests. There's always a diagnostic criteria. It's cast across at every level. The first line therapy is there. What is the preferred agent, the dose, the route, and then the duration? What is the escalation pathway? The first line is not working. How do you move? Do you move to the left or you should move to the right? The guidelines should spell it out carefully. It should cater to special populations. Those with chronic liver disease, those who are children, pregnant women, those with kidney disease. It should cater to everybody. When you take your formularies and BNF and things, it covers every population. Okay. There are monitoring parameters to track what is happening as you treat. And of course, there's always a referral criteria. That tells you what you should do if it's beyond you or beyond your level. Okay? So treatment guidelines helps us to optimize antimicrobial use. It helps us with the right choice of antibiotics, again, following the aware classification. So we know which agent to use for which condition. The right dose and duration, it reduces variation among prescribers. So one doesn't do something different. Somebody is underdosing, another one is overdosing. Somebody is abusing the antibiotics. And then it also helps us to contain resistance. So that the medicines we have, okay, I'm sorry, in the next few years, public health trials already. Now go to the wards, when I visit facilities, and I pass through the wards, you see Rosephine. Because once you rise the trials, you're afraid of what will come. The last time recently I wanted azithromycin. So I asked for Zitromax in the pharmacy 200 and something. Now okay, which other brand is there? The other is like 40 cedis. Now this one 35 cedis. Like okay. The same medicine, supposedly the same active ingredients. So if you enter a pharmacy and they tell you this one is 200, and the same instruments, they have another one for 35 cedis or 40 cedis. Okay, you then do what will you take if you buy the 40 cedis? You know that you are buying because that's what your pockets can afford. But you know already you are not going to get well. And therefore, within 3 days, if they are still not feeling to it, we'll come back and buy another one and go and continue. That's likely to happen. Okay. So, again, making sure that we protect our watch and reserve medicines so we don't lose them eventually. Okay. So the guidelines help us move from guesswork to precision therapy. Okay. So if you follow guidelines, you are less likely to guess in your management and in your prescribing. You are more likely to be precise because what you see in there is evidence-based. Okay. So we have indication-specific selection for our medicines. We have standardized dosing regimens and defined treatment duration. Okay, the previous presenter said that when you go to the wards, they don't close the duration of antibiotic dispensing, isn't it? So you see, a tap amoxicillin clavulanic, IV amoxicillin clavulanic, 1.2 grams, 12 hours. Case closed. Give it until money runs out, or patient is discharged. You determine. Okay. So those are challenges. But at least we have clearly defined treatment duration, which will prevent premature discontinuation and unnecessary prolonged courses, okay, which will all contribute to resistance. Then it also helps benchmark across prescribers. Okay. So the standards will help you determine which prescribers are going overboard and which prescribers are underperforming or which ones have issues. Okay, then you can now intervene. De-escalation logic. When you move from broad spectrum empirical to specifics. Okay, again, your standards will tell you that you start with A. Once you get the results and the results say is B, stop giving the broad spectrum and now give a narrow spectrum. Your standards will tell you that. Again, what gatekeeping for our watch and reserve medicines. Okay, that's also so there are a number of treatment guidelines that are available. Okay, fortunately for us as a country, we have a standard treatment guideline that is still awaiting. Yes. Yes. I thought it had been updated. We were just waiting some assets, but portions. Yes, every few months they will call that somebody has updated their portions. You should come and sit and look at it. Why you can't update the entire book, I wonder. But then we have the WHO aware antibiotic book, which you can look at. It will tell you all the various antibiotics and which class they belong to. We have a standard treatment guidelines. We have the WHO essential medicines list. Okay, then we have the essential medicines list which the country has. And that's why, because the pharmacists have a lot of money, they're able to keep up with the updates.
We have sponsors.
Your sponsors. Yes, your sponsors are still pharmacists, isn't it? So, pharmacists have money. Okay. So the aware antibiotic book basically is organized by clinical syndromes. It's a reference material from the WHO. But we are told that it should not replace our standard treatment guidelines. Then of course we have our WHO essential medicines list, where we are also supposed to look at and take some of our medicines from. Okay, that's also available. Okay. Then we have the Ghana standard treatment guidelines. I think there is a mistake. Updated on Elizabeth in Faggot. Should be every 10 years. So that's what we are trying to do. Yes, but I did it every 25 years. It should be updated. Okay. Yes. And then it should be informed by national antimicrobial resistance surveillance and local antibiogram data. Okay, so this is where our director of pharmacy and his team are working on to ensure that we have our surveillance reports and local antibiogram, which will be a template for most of us to also use or replicate in our facilities. Okay. And then again, we should ensure that when there is deviation from first-line therapy, it should be documented and justified. Okay. I always say that when teams are set up, you are as strong as you make yourself. really. You're only as strong as you make yourself. You decide that you are going to keep an eye on the airlines, strengthen the DTC, and make sure that you police what is going on. You can really get it done. Okay. And some of these things, and then we have our essential medicines. Okay. So for a sound treatment guideline, it should be developed by experts committee. It should be evidence-based. It should be cost-effective. It should have clinical algorithms. It should be regularly updated, and it should be aligned to the WHO models like the essential medicines list and the aware list of medicines. So the key takeaways: hospitals are high-risk amplifiers of antimicrobial resistance, and we require active, coordinated institutional governance. Okay, and that is not management. That includes you and I. IPC, DTC formularies, lab, AMS, and treatment guidelines. That's the big six. Work as one connected system. Okay. Treatment guidelines convert national policy evidence into consistent day-to-day prescribing decisions. The last but not the least, that guidelines should be evidence-based, driven by experts, cost-effective, aware, aligned, and it should be regularly updated. Okay. So this peer review, when they come asking for your standard treatment guidelines, you tell them you don't have one because it hasn't been updated. Okay. Thank you very much.
Thank you, Doctor. Please, do you have any questions?
You didn't introduce the next presenter.
Please, we still have Dr.
So we're going to look at the next one.
Please, let the lights now. Let the lights in.
So now that we have looked at our role as DTC units, how do we ensure that we institutionalize DTC and antimicrobial stewardship programs in our facilities? So that it's not another committee that has been set up every quarter. You meet, have a discussion, enjoy some snacks, take some, and let up and go. But really, day in, day out, work is being done. The facility can feel the presence of your activities or action as they go. So we are going to look at what stewardship is. Okay. Then zero in on antimicrobial stewardship. Look at strategic objective 4 of the GAP AMR. That's a global action plan for microresistance. Look at the components for antimicrobial stabilizers and what do we expect to see in the antimicrobial stabilizer team. Okay, so we'll start. What is stewardship?
A caretaker.
A caretaker. The Bible says we should be good stewards. We should be good caretakers. Okay. Caretaker, what else? Stewardship.
Service to someone.
Service. Okay, so we should offer service to others. Stewardship. Gladys. Direct. To guide. Direct or guidance. Gladys was my nurse when I was at Adabaka Polyclinic. I was somewhere 2013, 14, about. I still did that. She was my consulting nurse all the time. So stewardship. Okay.
Responsible.
Responsible. Okay. So what's antimicrobial stewardship? Responsible is antimicrobial caretaker. Antimicrobial responsible. Antimicrobial is our service. What's antimicrobial stewardship? Antimicrobial stewardship. Any of us? Want to try it?
Just rational use.
Rational use. Ensure rational use of antimicrobials. Rational use of antimicrobials. Okay, let me jump the components of antimicrobial signals. To who do we expect to see in the antimicrobial team? Stewardship team. Who do you want to see? You say myself. Okay, so want to see a prescriber? Who else?
Pharmacist.
Want to see a pharmacist?
Microbiologist.
Want to see a microbiologist? Want to see the lab represented?
IPC. IPC.
IPC. Quality. You realize that the earlier presentation spoke about the 6 major components, okay? And all those within that 6 should be represented in your antimicrobial stewardship. Okay, so basically when we talk about stewardship, we are looking at responsibility. Okay, being responsible for another. Okay, that's why we are told to be good stewards. We are supposed to take care of any resource that has been given us. Okay, we take care of the resource on behalf of the other or somebody else. So for this facility, the antimicrobial stewardship means that we have a team that is taking care of the antimicrobials on behalf of the hospital. Okay. So basically, stewardship is the careful and responsible management of a shared resource. Careful and responsible management of a shared resource. We want to ensure that it remains effective and it remains available for current and future generations. Okay, rather than being depleted by short-term unchecked use. What comes to mind? Balance, isn't it? Okay, we want to make sure stewardship wants to ensure that the resource is available for current and future generations and not depleted by short-term unchecked use. Because when we take antimicrobials, can't remember, from Fleming's time up to now, we are still using them, the antimicrobials. We are producing them and we are using them. It's finite. It will always be there. So if you don't check its use, it will come to a time when it will not be as available and reliable as we expect it to be. So overuse anywhere erodes effectiveness everywhere. In the past, the Caucasians were not interested in what happened in Africa. Today, when we cough, they jump. Because they know that I can cough in Accra in the morning and I'll be coughing in the US in the evening. Okay. So now when you cough in Africa, they jump. If you cough in Asia, they run. So if we develop resistance yet in Shai Osu Doku, somebody sitting in the north of Ghana should be worried because you can take a flight today from Accra to the north. And before you know it, you are spreading drug-resistant infections. Stewardship reframes prescribing from an individual act to a collective responsibility. You are safeguarding for the general good. So it's not about, as for me, that is how I do my thing. This is my preferred antibiotic for this condition. And you can't change it. No. Stewardship says that whatever you do as an individual affects the general interest of the population. So it's not just about you. The team has to ensure the right things are done. It applies across One Health. So human health, animal health, and agriculture. And therefore the environment. If there are chemicals being used in agriculture, it can have an impact on human health. If there is resistance in the animal population, it can pass on to the human population. So these things are things that should run at the back of my mind, our minds, even as we stay in this team, the DTC team, because there's a lot of work we need to oversee for the antimicrobial situation. And we've seen this, a part of this area. Okay? The burden of death expected if we do not act now. And for livestock, we are looking at about $1 trillion loss to the economy. Okay. So there's a lot of costs that we can incur if we do not practice good antimicrobial stewardship. So stewardship spans every sector, and we've already said One Health. It's not just about we the humans. What happens in the animal industry should be of interest to us. So if you know a farmer, a livestock farmer, who is mixing all sorts of antibiotics for in their feeds for the animals, you should be interested. You should be worried. Because eventually it will get to the human population. If they are spraying all sorts of things into our environment, it can have an impact on resistance in the future because some of the agents may be what we may be using antibiotics to produce antibiotics. It's important that we should be interested and worried. So what is antimicrobial stewardship? That brings the general concept of stewardship to the facility level. Okay. Stewardship is general, but antimicrobial stewardship applies to the facility level. So it's about ensuring that every antimicrobial decision is the right drug, right dose, right route, and right duration for the right patient. So 5 rights. Is it the right drug? Is it the right dose? Is it the right route? Is it the right duration? Is it the right patient? So it's not about restricting medicines. What is stewardship? It's not that the team says, I don't want you to use this medicine in this facility. No. They're just trying to align. No, now, okay, we still use align. Now the words keep changing. Now it's resetting, isn't it? They're just trying to align. Okay? To ensure that everybody does according to standards. So it ensures every antimicrobial disease, the right guard, dose, route, and duration. It's not about restricting access and operates through structured programs. It's not an ad hoc system. So what do we set to achieve when we undertake antimicrobial stewardship? We want to improve clinical outcomes because we want to reduce treatment failures. We want to ensure that when we prescribe something for a patient, it works. Okay, so we try to match therapy precisely to the patient and the pathogen. We want to minimize resistance selection. Because when we unnecessarily expose people to antibiotics, then resistance emerges. And once resistance emerges, it's likely that resistance traits will spread. Okay. We want to reduce avoidable cost and harm. Let's assume that you are taking a medicine and it's not working because of resistance. Then you need to go for a more expensive one. That's a lot of cost. Not just to the individual, but to the whole economy. Okay, so these are the things that we want to do. So improve clinical outcomes, reduce resistance selection, and reduce avoidable cost and harm to our patients. Okay. So whereas stewardship looks at a principle, antimicrobial stewardship looks at the facility. A program within the facility, what you should do. Okay. So antimicrobial stewardship is owned by the Drugs and Therapeutic Committee. Although there will be a team in the managing, that team reports to the Drugs and Therapeutic Committee. It operationalizes stewardship via audits, policy, and education. Okay. So the audits keeps coming up. This is very important. Okay. So the antimicrobial stewardship does not have a system for quarterly audits. It's like exit interviews, isn't it? And then you pick the food, they can check over the past 1 month what antibiotics were written. Are they according to a standard treatment guidelines? Okay, who are those going above or out of range? So that you can now go and do the education. Then we are failing at our job. It reports measurable indicators then to hospital leadership for action to be taken. So again, that's basically what we've gone through. Okay, so perspective on this and feedback, and then where prioritization is required, it needs to make clear. So these are the medicines that everybody can prescribe. For these medicines, we expect that what specialist level. So you see what the NHIA has done. Okay, that's an example of prioritization. It says there are these medicines you can prescribe at level A. These medicines have to be level B. This medicine has to be a specialist level. That's to regulate the medicines. Okay, and that can be done. Okay, that's prior authorization before you can dispense those medicines. So it ensures guideline-based prescribing. Okay, and it ensures prescriber education. So, this activity should be undertaken by the antimicrobial stewardship group. Audits and giving feedback, ensuring that you have a formulary prior authorization and the levels are adhering to them. Okay. Making sure that all prescribing is based on empirical evidence, evidence-based, based on your guidelines. And then also educating your clinicians on the aware group so that they know that, oh, this antibiotic, you don't just prescribe them. Okay. There should be education for them. Okay. So when we take strategic objective 4 of the Global Action Plan for Antimicrobial Resistance, there are 3 key areas it speaks about. Ensuring equitable access to the antimicrobials, appropriate use of the antimicrobials, and safe disposal of the antimicrobials. How do we ensure equitable access? How do we ensure appropriate use? How do we ensure safe disposal? So equitable access, and this may look like, oh, it's beyond us. There's no facility wahala, but it is. Some of them apply to the facility level. Okay. So our supply chains, our forecasting, our resilient measures, even at the facility level. Okay. What measures is in place to ensure that we are getting adequate quantities of our access medicines, our medicines? How are we forecasting and projecting our consumptions? It is important. Okay. Our formulary optimization, market intelligence. Okay. We can bring it to and do intelligence in our facilities to see what our prescribers are doing, what are they using. Okay. Strategic sourcing, pooled procurement. Okay. Expanded manufacturing capacity. We say we don't manufacture, but I used to manufacture sanitizers. Yes, and it is important for us as well. So in-house we do something. Okay, IPC is one of the core pillars, isn't it? So if you are manufacturing sanitizers, are we doing the right way, the right concentration, so that we can reduce infection, we can reduce spread of infections? Okay, and then of course we should remember it is one health. So it's not just about humans, it's also about animals. It's about the environment. Okay, so smallholder farmers and then conflict areas should also be taken into account. So when we look at access, equitable access, here this is WHO, so it's talking general, but we are bringing it home to Shai Osu Doku and saying that how do we look at our supply chains and forecast? What resilient measures are there to ensure that this universal health coverage is covered for our entire facility? Everybody who works in here, how do we ensure that they get the medicine they need? We don't run out. So they go out there and buy something which is outside our formulary. How do we ensure that our formulary is optimized? What intelligence do you have on the ground to know who is prescribing what? Okay, and that's where the policing comes in, the antimicrobial stewardship activities. Okay, how do we strategically source our antimicrobials? Okay, how do we pull our procurement to make it cheaper? So all this can be applied to us locally. It's not just about government of Ghana and what they are doing. Are they up to date? Is it evidence-based? Are we adhering to our guidelines? Are we using essential medicines? Is it aligned to what WHO has? So even if we develop something here, we can question to see whether it's or not. Or is the national essential medicines responsive to the WHO model? Okay. Are there any evidence from antimicrobial use surveillance that informs our prescribing? Okay, I told you I stopped trusting Kefroza way back in 2015-16 when I was at Rich. And I still haven't really gotten over it. But it may be what is working here. It may be what is working here. Okay, maybe back then it wasn't working for us because we get a lot of resistance. But here you don't have resistance in Shai Osu Doku. So it's working for you. So what informs your prescribing is very important. Okay. And how are you strengthening your workforce through education and training? Okay. Some will think it's a waste of time. I remember one of my first directors I worked with, Dr. Obiapore. How many of you know him? I heard of him. And the old squad, you know him. Okay, then I was there at the school hospital before I moved to Greater Accra Hospital. I've forgotten the exact day, I said it was Friday. Every Friday morning, clinical meeting, he's there. Who's the medical director? But every Friday morning, he'll tell you that the only person not expected to be at the clinical meeting is the one on emergency duty. Everybody else has to be there. 15 minutes after time, he closed the door. He himself will sit. Because he said, it is important, the education and training is important. We need to learn to be able to do the right thing for our clients. So it's important that we look at that. And then safe disposal. Take back schemes for unused antimicrobials. That. You have a system where suppliers can pick up what we don't use or near expiry products. That should be there. Okay. Do you have producer responsibility regulations that addresses how disposal should happen. Okay, how do we integrate disposal into a healthcare facility and household waste system? What system do we have in place as a facility when it comes to disposal of antimicrobials? To ensure that they don't end up in the environment, somebody goes to pick them up and changes labeling or abuses it. We know how to treat free things. Okay, so we need to come and take some. One is environmental pathways for resistance. Beyond these three, beyond the three, are other support systems. Okay? Remember that we spoke about equitable access, ensuring that everybody can get it. Okay, so applying to our facility, we want to ensure that everybody who walks into Shai Osu Doku has access to the right antimicrobials. We need to ensure that antimicrobials in Shai Osu Doku are being used appropriately. And we need to make sure that they are being disposed of what? Safely. Okay? But we can't have equitable access, we can't have the appropriate use, we can't have safe disposal without the support of some areas, and that's the diagnostic stewardship. Okay, and that helps guide what we actually prescribe and know whether there are resistance rules or not. Regulatory strengthening. Okay, that will regulate use of antimicrobials right from importation or manufacturing all the way down to use and disposal. Are there regulations? Otherwise, everybody will do what they want. So what are the regulatory frameworks to ensure that the right thing is done at every level? And of course, substandard products. How do we ensure that we reduce substandard products? That's also important. So beyond what we do as a facility, there are things external to us that we also need to be mindful of to support the work we do. So antimicrobial stewardship. Everybody is going to talk about one of these. Okay. In the previous one for standard treatment guidelines, we spoke about how many components. We said 6, isn't it? Now here we have another 6. For DTC, yes. So we have another 6 here, components of antimicrobial stewardship. So let's take them one after the other. So the first one, leadership commitment. Who will talk about it? Chief, can you talk about leadership commitment? What comes to mind?
I think it speaks for itself. The management has to be committed to the antimicrobial stewardship. So they have to support and ensure that the meetings and then the others, go on successfully.
Yes. Okay. You said the meetings and the you mean the refreshment and the
No, I mean the activity.
Oh, the activity.
So even though the snacks and those ones are important, at least the work has to be done.
The work has to be done. So they support with the soft issues and ensure the hard things are done. Okay. So management also has to be interested. Okay. In ensuring that the antimicrobial stewardship takes place. The audits are done, feedback are given, what you need is provided, staffing is provided, if it's computers, it's provided, etc. Okay. Accountability. What comes to mind? Okay. So this is leadership commitment. Chief, can you see? Not well. So I should read for you and you interpret. When I say should, you just say ask yourself. So hospital executive and clinical leadership should dedicate their financial, human, and IT resources to the program, so that the program can function. Okay. So is there a formal recognition of antimicrobial stewardship in this facility? Is there a formal recognition? Do members have protected times so they can do the work of antimicrobial stewardship? Or you have to finish your shift and close from work and do this assessment? Management follow that. Okay. But this is important.
Yes.
Okay. While your leaders also recognize that, okay, if it's once a week, so if you are working 5 days a week, 1 day is antimicrobial stewardship. So your team members will have 1 day block for that activity. Because if you are on shift the whole period, and you can't leave your shift to go and attend to this, then it won't be done. So it's not part of strengthening the team. Budget line for stewardship activities, training and data systems. Okay. Do you have a management member of the team, or are they reviewing your work? Is it being reviewed by the Drugs and Therapeutic Committee? So these are all important. It's part of the leadership commitment. So it's not just making sure that your TNT or your staff are delivered, but the actual work itself is also done, and you really have the support for the team. Then there's the accountability side. Accountability. Chief, can you accountability? Your name, please. Jonathan. Accountability.
So a single name individual or co-leadership team is formally responsible for program outcomes and reports through the entities.
So who is in charge of the antimicrobial stewardship team?
We have the clinical coordinator and the head of pharmacy.
Who is an infectious disease specialist?
So is it a chair or a co-chair? So you have a co-chair. Okay. Any table? You have co-chairs. Okay. So there should be a lead who has defined authority and knows exactly who to report to. Okay. Clear terms of reference. You say you are part of that.
Yes.
Do you have a letter?
Yes.
A letter designating you as a member?
Yes, there was a letter.
No, not the 2023 one. I mean,
This year. Oh,
We have for last year.
yes, the time that the team was formed, appointing the members. As and when there is a change.
no. So the membership was for how many years? What was your term of reference? You were appointed for, or you were designated for how many years? Until you leave.
Unless maybe your roles and responsibilities change. As you move on, then maybe
Okay, so again, it's important. Okay. Are you reporting indicators to hospital leadership? Is there reporting from that regularly? That shows that this is a report we are expecting to receive from you, whether mentally, etc. Okay. Are there defined consequences and escalation pathway for non-adherence? So during your audits, you find that A, B, C, D is not adhering. Okay. And then you clearly define pathways as to what you should do next, beyond just submitting a report. Okay. So again, this is all to strengthen and build it. These are areas you really need to look at. Okay. It's not just about setting the team, but it's making sure the team works and is supported to work. So accountability is important. Then we have the drug expertise. You have dedicated pharmacotherapy expertise, and that one is here. So you have a pharmacist co-leadership with the agents. Okay. You have a working knowledge of local antibiotics and their work application, capacity to review those and adjust medications where necessary. And then you also need to bridge prescribing process with the formulary and your procurement decisions. Okay. Then actions and interventions. Again, we keep coming back to the same prospective audited feedback. So this keeps coming up. Two things keep coming up. This prospective audit, it doesn't just say audit, it says what? And feedback. So anytime you audit, there should be feedback. And then protocols and guidelines keep coming up. So those two, always. You should have your guidelines and protocols. You should audit to see whether there is adherence or not and provide feedback. Okay. And then of course there is the prior authorization. So again, clearly you need to have that. Okay. Some medicine should be clear who can prescribe And then IV to oral switch programs. At which point should you switch from IV to oral? Okay. What are the protocols for switching? Okay. Otherwise, somebody will be on IV for longer than necessary. Some will be on shorter than necessary. Some will move from one spectrum antibiotic IV to another spectrum oral. This will not be very helpful. Okay. And then tracking and reporting. You can't work without tracking and reporting. So there should be metrics to monitor. Okay. Can you track antimicrobial consumption in your facility? Can you classify them according to their work category? Welcome back. We're waiting for you. So yes, I'm happy you are back at this time. Okay. So can you track your antimicrobial consumption and look at their work classification to know which of the antimicrobials are being consumed? Okay, which categories are they? Are you doing a lot of watch as against access? Okay, as for the result, it's a bit more difficult to come by them. Anyway, they are more for this program medicine, but the watch medicines we are using. Okay. The facility antibiogram has it been updated? When was the last time it was updated? I'm sure Kevin's come, so we'll say recent. We just feel it change the date. Okay. But it should be reviewed at least annually. So even if you change the date, you review it, isn't it? It should be reviewed at least annually. Quarterly antimicrobial use reports submitted to the DTC. So when the DTC meets, what do they look at? These are some of the areas we can look at. Okay. And then of course we have the national data routine reports. Then education. Are we educating our staff? Okay. Unfortunately, we have a very high turnover rate. A lot of our prescribers. So it requires continuous education and refresher training. Orienting of new prescribing and dispensing staff. Okay. CPDs linked to our standard treatment guidelines and our updates. Do they know about this? Okay. Case-based feedback sessions, which reinforces appropriate prescribing. So when we go for clinical meetings, are we just looking at, the patient was given this antibiotic, the patient responded and was discharged? Or we are looking at this antibiotic that was used, what was the rationale behind prescribing it? Was it the most appropriate? Could it have been this? Next time can we go for this? What was the duration of use? Was it the appropriate duration or not? How was the switch done? Was it done right? Okay. So it's not just about patient recovered and went, or patient mortality meeting. Patient was given this, failed to respond and died. But look at the antibiotic aspect of it and question interrogate how it was done. The competency-based antimicrobial resistant content integrated into our in-service training. So anytime we have a clinical meeting, we should also be looking at the antibiotics and how they were used. Okay. So for a good antimicrobial stewardship team, at least this is the minimum that we should see. At least there should be a physician or infectious disease specialist or champion, not necessarily specialist, a champion. Somebody has to be a champion interested in infectious disease conditions. It should be an AMS pharmacist, a clinical microbiologist, an IPC nurse, okay, a data officer, and then again the management should be there. Because of course linkage to the drugs interactions committee. And supporting them. Okay, so the roles are here. When was the end of that? You know what they do? The physician, physicist, isn't it? The pharmacist, and the microbiologist, and the case physicist. But we know the role they provide. Okay. But basically, the physician is supposed to also help ensure that there is prioritization for the watch and exam agents. The pharmacist looks at our formulary and procurement and ensures that the right decisions are made. And also prospective audit and feedback, very key for the pharmacy team. You should have a dedicated team that does this frequently and provides feedback. So that the head of pharmacy can take this to management and say, that's what I'm seeing in our facilities. Head of clinical services, how do we address this? Okay. Then of course the clinical biology, microbiologists who will look at emerging resistance. Okay, and inform management accordingly. Okay. Then we also have the infection control nurse, the data officer, and then the DTC and hospital management, and the roles they play. IPC looks at IPC surveillance data and supports our okay, and provide the necessary response. And then the management and DTC, okay, we'll look at policies and ensure resources are made available for the antimicrobial stewardship team to work and work effectively. So in summarizing, if you want to institutionalize antimicrobial surveillance, it is not an ad hoc team where you pull your favorites and favorites can you put a list together and then let's form something and do something. No. Okay. Antimicrobial stewardship is how an institution expresses stewardship, how we take care, how we protect resources that have been made available to us. And in this case, we are talking about antimicrobials. We need to ensure equitable access, appropriate use, and safe disposal to our antimicrobials. That is our mandate. Okay. And we need all 6 components, not just policy alone. So a multidisciplinary team is important. That will report through the Drugs and Therapeutics Committee to ensure that antimicrobial stewardship becomes a permanent feature of our facility. Thank you very much.
We are really in enlightened. Yes. And we are going to practice as a DTC team, guided by these principles. What we learned, what we have got yesterday, and what we are bringing on today. We are going to strengthen our DTC team to project Shai Osu Doku pharmacy. Hospital. The limelight forgive me. I have a presentation. That's right. I'm going to do the ensuring access to appropriate anti-antiviral.
Yes, so let me ask something. This is very interesting. So thank you so much, Doku, for that elaborate presentation. We are so privileged to have you here today. Thanks so much. I think he made a very significant statement, which for me is so important. So that when things are set up, you are only as strong as you set yourself. It will only come from somebody who is experienced. You see that in our levels, especially when you start moving to a higher level, at the regional, national, whatever you do. So you see, as an AMS DTC team, a lot depends on how we also enhance our competencies and skills. If they said that lack of knowledge, lack of confidence, like the same way. And I always say that confidence is based on competence. The true goal will always go what? Hand in hand. So let's ensure that we always update our confidence skills. But he also made a very critical point in relation to continuous education, improvement, clinical methods. I want to know what form does in-service training take within the facility, and how often is it conducted? involved like this, how often is that?
So for everybody going to answer, but
No, not
okay.
every team.
But most of the training programs that we have, medical meetings coordinated with the in-service. So all newly posted staff, the in-service is the unit that they are received, they are oriented, and the various things that are in the facility they are taking through. So for us, for instance, the training that we do for the new clinicians, we do it with the in-service. So as soon as they are done with the orientation of the new staff, especially the clinicians, then we can go to the students. So they organize our clinical meetings, and most of the other programs that we have is coordinated with the in-service. Yes. I don't know if you have missed something. That's it.
So how often is it done? When it comes to this administration, how often? Is it weekly, like you said? So like once a month or once a week? So the last Friday every week?
So those
No, average.
So now for food you have so last Friday.
The last Friday of every week. So how often do you organize in-service training? Okay.
So our clinical meetings is done once a month.
Once a month.
Yes. The mortality, one is mortality meeting. So they are both clinical meetings, but one is for mortality and one is for like a galactic, like a teaching, like that's for like various departments, surgical, medical, obs and gynae, EA lab, they all have portions to their teaching. So it's twice a month. Yes. Then we have wait. We have meetings for internal medicine on Thursday. Then we have obs and gynae also. I think Tuesday, and then surgical is Wednesday.
All right. So it means a learning organization. Thank you. Next is the learning organization.
Okay, good afternoon to us all once again. Good afternoon. So my name is Mary Epe. And I'm taking us through ensuring access to appropriate antimicrobials and other health products. So we, throughout our training, we've been talking about availability of the antimicrobial agents. Now we are coming to discuss how we will ensure access to them and other health products. We are going to discuss why access matters. We will discuss the access framework. We will discuss the broad imperative, quality and supply risks, the 5 pillars for scaling access, and then diagnostics, vaccines, and synthesis. So, access as a universal health coverage. Access as a universal health coverage target. WHO has been tracking countries on how well they are doing when it comes to achieving the universal health coverage targets. And one of the key indicators to ensure that you are approaching or achieving your universal health target is actually assessing the country if the country have access to safe, effective, quality and affordable essential medicines and vaccines. Why are we talking about vaccines here? is vaccine also becoming part of the DTC? We are talking about vaccines because we learned that if we take IPC, that's infection prevention and control, very seriously, we won't end up contracting the infections, and then we won't end up using a lot of antimicrobial agents. Therefore, there wouldn't be any antimicrobial resistance issues. Then, vaccines play a role here. Apart from adhering to IPCs, can we think about also encouraging the use of vaccines, vaccinating the children, we the adults, to getting vaccinated so that we are prevented from contracting these infectious diseases, which makes us end up using a lot of antimicrobial agents, leading to antimicrobial resistance. So the core coverage indicators for universal health coverage is access to safe, effective, and affordable medicines. They also use the foundation of care, that's the public health interventions, to also track countries to know how well they are doing when it comes to universal health coverage and also achieving the SDG goals and targets. So we are looking at the scale of the problem. Access to medicines is a major global concern. Why is it a major global concern? It is because about 1/10 of the global population don't have access to essential medicines. And when you come to our region, low and middle income countries, 50% of us don't have access to essential medicines. Our procurement systems also make us lose out when it comes to access. The bureaucratic way of procuring medications or essential medicines make us end up even procuring the stocks as twice the price as what can be gotten on the global market because of our procurement processes. The delays makes us not have access to essential medicines. And when we end up procuring these essential medicines, about 15 to 25% of them get expired before our clients get to use them. Expiries to prevent us from getting access to essential medicines. Now, we have to discuss why this is an urgent case in Ghana. This is very urgent because there was this point prevalence survey conducted in our 7 facilities in the country, and we realized that about 55% of our inpatients are put on antibiotics. And over 70% of these antibiotics are resistant to the common causative agents that are found in our health facilities. And if we don't do anything about this, about 1.1 million of deaths are linked directly to antimicrobial resistance issues in our country. Apart from that, the access group of antibiotics currently is about 60%. By the year 2030, it will move to 70%, and even the 60%, we are struggling to achieve that. And if it's moved to 70%, what becomes of us income? So we are saying that both access, that's sufficiency, and insufficiency will all lead to antimicrobial resistance. So medicines must be appropriate, available, and affordable. when we talk about appropriateness, how are we selecting our medicines on our formularies in our facilities? The DTC team, are we very intentional about the selection of these medications onto our formularies in the facilities? Are they guided by evidence? Are they guided by diagnosis? And are they matched to actual therapeutic needs? Or we just select it anyhow, thinking that for us in Shai Osu Doku, we usually see malaria cases. So why don't we include more of anti-malarials and not base the selection on therapeutic needs? Let's look at availability. How are we making sure that our essential medicines are always available at the point of care? We can go in for the medications and it can be at the stores. There's nobody to request them from the stores to the pharmacy. The prescriptions come and the medications are not at the dispensary. The store manager is not available. They have closed and gone. This doesn't make the product available at the point of care, though it is available at the facility. What about our supply chain systems? Are we looking at making it very resilient to support our access to the essential medicines? Let's talk about affordability. Are our prices very affordable for our clients? Or are we making sure that most of the commodities are on the NHIS list to support affordability for most of our clients in the facility? Let's talk about the dual imperative here: access and appropriate use. We know that when we have a lot of access to a product, we end up misusing them, over-prescribing them, self-medication. And at the same time, if we don't have it, we don't end up having our clients treated efficiently because the products are not available. Usually when we don't have efficient access, we end up with untreated infections. The client came, the product was not available. We may write it for the client to go and buy. The client doesn't end up buying it, and the infection is at the end of the day not treated. The patient end up also getting substandard products or counterfeit products. Because the patient came with a prescription at the pharmacy and the product was not available, we wrote the product for the patient to go and get outside. They walk into any pharmacy or over-the-counter medical seller or even in the market. They meet them and then they show them the prescription and then they are given any substandard product to go and use. Let's talk about diagnostics. As we are talking about availability and access to essential medicines, what about the diagnostics too? Do we have the tools at our laboratories to conduct those antimicrobial sensitivity tests before we prescribe for our clients? We must make sure that even the labs too have access to all their reagents and equipment as a DTC team. Looking at the overuse and misuse, at the end of the day, self-medication, because the stocks too are so much more available, some end up in the arms of these are farmers, our poultry farmers, and they pour it in water for their dogs and the chicken to be drinking. So how are we controlling the stocks as a DTC team in our facilities? Let's talk about the 3 pillars of the Objective 4. We discussed some strategic objectives yesterday about the GAP, that's the Global Action Plan on Antimicrobial yesterday, whereby we spoke about research and innovation, access and knowledge gap. You spoke about most of the objectives. So with the Objective 4, we spoke about equitable access, appropriate use and safe disposal of these essential medicines we use in our facilities. Talking about the access, are we making sure that what we are stocking in our facilities are the best of quality, especially when it comes to the antimicrobials? Are they always available in the facility? Are they also available on our NHIS list, so that those clients who cannot afford anything, once they have their NHIS card, they will be able to get access to these medications? Let's talk about the appropriate use of these agents. Are we making sure that we are prescribing appropriately, backed by the antimicrobial sensitivity test before we prescribe? Let's talk about the safe disposal of our medications. How are we disposing of the expired medication? In the first place, as a DTC team, why do we have to sit down for some of our medication to get expired? How are we also collaborating with the public health division, especially those who handle the vaccines? How are we collaborating with them to dispose of their empty vials at the end of their vaccination campaigns? Are we leaving the vials around, whereby we find them in some of the drinks, or we are making sure that these vials are incinerated appropriately? The DTC team do collaborate with the public health division, especially during vaccination campaigns, to make sure all these things are really disposed of, especially even the gloves that they use during the vaccination campaigns as well. Let's look at what drives poor access to essential medicines and diagnostics in our facilities. The first driver is poor selection. Once we don't select the right medications on our formularies in the facilities, we know that we wouldn't have the right medication at the right time, as Dr. Bro-Mensah taught us, to make sure we have the right medications at the right time in the facility when we need them. Let's talk about unreliable supply chain systems. Is our supply chain that resilient to support availability of commodities all the time in our facilities? How well are we looking at building the capacity of our supply chain personnel in our facilities? Are we supporting them to get to know about the maximum and minimum stock levels that we should have at all times? Are they supported to refresh their minds on the reorder level, taking into consideration the lead time, to always make sure that we have the stocks available in our facilities? Let's talk about inefficient procurement. The procurement section. Are they part of our DTC team? The procurement team. Are they part of our DTC?
Yes.
Great. Yes. Good. So how are we, from time to time, supporting them to also know that without them, the essential medicines might not be available and also making sure the procurement processes are really streamlined to support access of essential medicines in our facilities at all times. Let's talk about quality and supply risks. Counterfeit and substandard medicines. How are we monitoring our stocks in the facilities to look out for these substandard and counterfeit medications that we stock? We know that we can't use our naked eyes to know at some point when the medication is substandard, but with very intentional observations, we can fish out some of these substandard medications in our facilities. Research is telling us that 10 to 20% of sampled medications in developing countries are substandard because they fail quality tests. And 28% of these failed quality tests products are antibiotics. So therefore, as a DTC team, how are we collaborating and making sure that the stocks that we have are of very quality standards to prevent any antimicrobial resistance issues in our facilities? Let's talk about expired medicines. They are a very costly failure in our system. It is said that 15 to 25% of procured medications get expired before they get to be used. And sub-Saharan Africa, we are losing about $12 billion on expired drugs alone. So in the first place, we don't have the money, and at the same time, we are sitting down for most of our stocks to get expired and losing out lots of money that can help us, strengthen our health system. And at the end of the day, when they get expired, to disposing of them is a lot of money that we usually push into the destruction of these expired medicines. So as a DTC team, are we going to probably support each other to make sure that we don't get these expired products all the time and end up using a lot of our funding to dispose them of? Let's talk about 5 pillars for scaling up access. How are we going to scale up access of these essential medicines in our facilities? First one is to make sure that we are selecting medicines very carefully onto our drug formulary, and also making sure that the formularies are optimized. Are we updating our formularies in our facilities? Talking about forecasting and quantification, are we doing it effectively to make sure that we don't overstock, which ends up giving us lots of expiries in our facilities? Food procurement, we get very effective prices when we conduct food procurement for our essential medicines. Workforce capacity development. Dr. Mensah was talking about workforce capacity development and was asking how frequent do we undertake some capacity building and training in our facilities. So workforce capacity development is very essential. So when we take the careful selection of medications, are we actually guided by the treatment guidelines when it comes to selecting medicines to be used in the facility? Are we also guided by the WHO Access Watch and Reserve classification when it comes to the antibiotic selection? Are we also looking at selecting the medications that supports our therapeutic needs in the facilities. When it comes to the formulary optimization, how often are we updating our formularies in the facility? And we know very well that when we keep updating them, we will remove all obsolete medications that are found on the formularies. So as a DTC team, we have to make it a key principle, part of our principle, that we will always make sure we update our formularies that we use in the facility. Let's talk about forecasting, quantification, and supply planning. How often do we do forecasting and quantification in the facility? And our quantification, is it backed by our consumption data, or we just assume that this particular medication, last year we used about 10 cartons. So this year, let's just add just 2 cartons to it and order, or it's really backed by our consumption data in the facility. And if we really do our forecasting and quantification very well, we must know that the consumption should be reducing year on year if we do them very well, and also make sure that we are practicing our IPCs and making sure we are using antimicrobials very efficiently. Our consumption of antimicrobials should be decreasing year on year going forward. Are we also looking at getting a very good integrated logistics management information system that once we input our consumption, it can forecast the quantities we will need for the next year or 2? So we know that our forecasting and quantification are backed by data, and it is very accurate to avoid overstocking and understocking. Talking about pooled procurement, are we thinking about procuring our stocks, thinking about buying together and getting very secured prices, and also quality and also supply security? We know about the framework contracting that we use. I don't know whether this facility to employ the framework contracting. You don't use it. Oh, okay. All right. Yes.
Yes.
Oh, okay. Then you mean we can consider that as pooled procurement, so that we get very affordable commodities, quality, and then supply security too is also assured. Let's talk about workforce capacity building. How often do we carry out our training sessions in the facility? Have we considered including the supply chain personnel too in our trainings to make sure that they are also ordering and bringing us very quality products, and also making sure that they don't sit down for the stocks to go stock out completely before they are now rushing to the medical stores to go and pick stocks for us? How well, as a DTC team, are we also considering making sure we involve them after our meetings? We give them the feedback for them to know that this particular product is always stocked out in the facility. How well are they also going to help support us so we don't always experience stock out? What about the labs? Are we also thinking about them, the lab personnel, to make sure that they are also giving us very good antimicrobial sensitivity reports to guide the prescribers in delivering very quality service to our clients. What about our formulary management? Are we managing the formularies we have in the facilities very well to support access to essential medicines? Beyond the medications, how do they all fit together when it comes to access to essential medicines? Are we looking at only the essential medicines, or we are looking at the diagnostics as well? The diagnostics, how affordable are they? Are we getting it for them? And how is it supporting the prescribers? The labs, are we also looking at making sure their reagents are always available to support the labs for prescribers? Vaccines, how are we collaborating with the public health units to make sure the vaccines are available? We know, for example, if the babies are vaccinated against tuberculosis and all the infectious diseases, we won't end up using the antibiotics on them because they are not contracting the disease in the first place. And that will reduce antibiotic use, and that will reduce antimicrobial resistance. So when we talk about the pillar cycle, when we select appropriately and we optimize the use of the formularies, and we forecast efficiently, and we procure adequately, and we build the capacity of the staff, we can be ensured of quality services in our facility. And it can be the responsibility of the DTC team to make sure that this cycle is closed all the time. What are the key takeaways of these presentations? We spoke about access as a failure that can drive antimicrobial resistance, because once the medications are not available, our treatments are not going to be optimal. We spoke about the 3 A's, that is appropriate use, availability, and affordability of the essential medicines. Once the client cannot afford the medications, the prescribers will write and they won't be able to procure, and at the end of the day, treatment outcomes becomes a challenge. Talking about quality, how well are we monitoring the stocks to fish out those counterfeit and substandard medications? How well are we monitoring our stocks to make sure they don't expire on us, for us to end up disposing of them with the little money we have in the facility? Talking about the PACO-B, the foundation, how well are we building the capacity of our own selves and our colleagues to make sure that service delivery is optimal and getting us very effective treatment outcome and reducing antimicrobial resistance at the end of the day. Thank you very much.
Thank you very much, Mary. Please, do you have any questions for our sister? Please, are there any questions? Or you are tired? Director, please, you have any questions?
Yes, I do.
Yes, please, Director.
All right, thanks so much. For me, this is not a question, but for me, it's a contribution in relation to workforce capacity. So, I think touch on forecasting, contribution, supply planning. I think all these expiries we're talking about is as a result of for forecasting and contributing to supply planning. I'll encourage all of us as colleagues here to take supply chain issue very, very seriously. Because it's not the work we do. As for the pharmacists, it's not doing that supply chain. We know that.
Yes.
Or we don't know that. Pharmaceutical supply chain is part of the work that you're supposed to be doing. And luckily for us, the Ghana College runs a specialist program for pharmaceutical supply chain. Although the service has some challenges with it, it doesn't prevent us from going to the college to specialize in that area. It holds a lot of future for the profession. For me, I think that the profession, partly our future lies. So we shouldn't joke with it. And for those of us who have interest, let's try and do that. I've always maintained in the service cycles that anybody who control the supply chain of your profession ends up controlling the profession. You get me? In other words, if somebody controls pharmaceutical supply chain, he ends up controlling pharmaceutical services. You get me? If somebody controls laboratory supply chain, he ends up controlling laboratory services. So I'll urge all of us to take serious interest in that area as much as we can. Thank you.
Is that all? We have extra questions. Oh, where is it? I think we now move on to the next model. That's ensuring access to appropriate antimicrobials. So, Mr. Clark, ensuring equitable access. Okay, so that's yes, that's the head of pharmacy. So yes. This morning I saw my director with cell sampling. So as part of the DTC, actually the action plan, there's not only for the head of pharmacy, it's for the DTC team. It came as a short notice, so I jotted down something. I told my boss that later I'll type it and send it to them. Basically, when Dr. Mensah was giving this for you. Dr. Mensah was when Dr. Mensah was giving his presentation, I was mourning. Yes, I was mourning because most of the action plan that the team have put together is basically what he was talking about. Yes, basically it was what he was talking about. So for the first, actually the action plan is going to be for 2027 because 2026 half year is gone. So for next year, the subsequent years. So our first strategic objective is we are going to strengthen our DTC. Yes. And our key activities is to reconstitute the multidisciplinary DTC, which is updated, okay, with terms of reference. And the responsible unit is our MEDSU, Dr. J. And our timeline is every quarter. You know, we have the DTC team already, okay, but we'll make sure if we have to add or we have to cut any other member who's going to help strengthen the team, we'll do it based on our frequent meetings and what's especially with antimicrobial resistance, based on the trends. So when we have to add, we need our health information officer to be more active within the team. We'll do it. If you are going to make sure our laboratory scientists is going to help us with the antimicrobial resistance within that quarterly or within that period, we will invite him to come. And as we said, with even our procurement manager or their internal auditors, yes, you are going to involve them. So, and
clarification. You are reconstituting. Okay, what is the exact activity? You read it. The first strategy is to what?
Strengthen. That's not the only thing you're going to do.
Yeah, the timeline you put to it is what I was a bit. You are strengthening it how? By you read it all.
I said we are going to reconstitute the multidisciplinary DT team with updated terms of reference.
Which is excellent.
Yes.
And the responsible person.
Yes,
excellent.
I meant to.
But once when he said like quarterly, that's what got my
The timeline.
it should be once.
Yes. Actually, with the DTC team within this facility, we meet every month. Every month we meet.
That's not the reconstitution. That is your.
Please forgive me. Forgive me. Yes, it's once. Yes. Please forgive me. Forgive me. Okay. And the second on the list is conduct monthly DTC meetings. Yes. And the chair is DTC chair, who is the Metsu.
So far, are you able to do monthly or quarterly?
Please, yes. We are not able to meet in person. We do Zoom meetings. That's what we do. Then review hospital medicine formulary annually. Yeah. And the head and the person responsible is head of pharmacy, is Dr. Sima. Then review medicine utilization and prescribing trends. Down to the person responsible is the DTC team, the committee. That will also be monthly. And with the indicator, I'm going to report a report that we produce. That's when we do our RUM and RUM surveys and excuse me. Yes, quantity balance surveys, yes. And also when reports from antimicrobial stewardship team, the committee response that we get from them we also use to review our medicine utilization and prescribing patterns. And review ADR reports. That one is going to be, but that will also be monthly. Yeah. Then we are also going to strengthen our IPC. That's our second objective, yes. And conduct annual, that's under their key activities. We are going to conduct annual IPC risk assessments. And our IPC team, that is the total collective. TQM team would help us with that. When we assess our reports, that will be our indicator. That's what we are going to use in our assessment. We are going to ensure availability of IPC supplies, example, PPEs, hand hygiene materials like frequent flow of water, liquid soap availability within all the units. Yeah. Tissues and all that. And our administrator and our store managers, they are going to be the persons responsible. And that one is going to be continuous. That's the timeline. And our indicator is stock availability, which is going to be more than, we'll make sure it's more than 95%. They're just going to be, I'm hoping it will be feasible. Conduct monthly IPC wards and units audits. And the IPC focal persons within the units. Yes, we do that. And that will going to be monthly. And now the indicators will be the audit reports. Implement hand hygiene improvements, hand hygiene campaigns. That one to the IPC committee. And it's going to be continuous too. Then our third strategic objective is strengthening AMS, antimicrobial stewardship. We are going to develop AMS implementation plan. So with that, the team is going to do that. We are hoping it to be, at least if within the year, something that will last or that will be continuous within the year. We are hoping
This year or next year?
next year, 2026 and 27. We've exhausted half of, or this year, half of it. So going forward, we are going to do that. Develop antimicrobial prescribing guidelines. That's the team. That one to, at least we are hoping every month. As I said, base the prescribing
prescribing patterns of antimicrobials being prescribed by clinicians within the facility. And that one, we're going to use the guidelines available to do that. To introduce antimicrobial consumption monitoring within the pharmacy and at our consulting rooms. Down to the pharmacy, we the pharmacist and the pharmacy staff will be responsible for that. And that's what we are going to be doing that. To introduce antibiotic approval or restriction policy for selected medicines. And to the DTC team and the antimicrobial stewardship team with that. We are going to implement the policy. We have implemented policies as an indicator. Then fourth objective is surveillance. We are going to monitor antimicrobial resistant vaccines within the facility. So our lab scientists are going to help us with it. That is going to be monthly. And the indicator is more health-associated infections within the facility. That's what we are going to use to monitor. And also develop annual cumulative antibiogram. So I think after this program, we are going to, from when we are being held to develop our own antibiogram, then we will start. Yes. And that will be done annually. Then capacity building, as I said, daughter, we are going to train all our clinicians and staff on antimicrobial prescribing, being prescribed rationally. So the antimicrobial stewardship team, committee, they are going to be responsible for that. Then train nurses on IPC practices at the wards and all the units, hand hygiene, proper waste segregation and disposal. Then our fifth objective is community engagement. So our public health team too is here to assist with that. Conduct antimicrobial awareness campaign. That's when we are celebrating our antimicrobial awareness week. So our health promotion team is going to help us with that. And our indicator is campaign that we conduct. We are going to monitor and evaluate. Monitoring evaluation, that's our safe strategic objective. Annual programs that we conduct on antimicrobial resistance, we are going to evaluate them. Yes. And down to the hospital management to be the responsible units. And the timeline is annually within the year. And we are going to use evaluation reports to evaluate that. Please, in a nutshell, that's our action plan we plan for next year. Yes. So our action plan for next year, 2027, is based on the training we've had so far. Yes. Thank you very much.
For now, do you have an action plan for
Yes, we have, but I don't have it with me right now. It's on the board. Okay. Please, let me try and go over.
Oh no, you don't need to.
Okay. I think it's almost the same as, but just that maybe there might be some additions.
Please share with me what you have this year.
Please, I hear.
Please.
It's not so much of a question, but just at the IPC training. Second.
No,
So for the IPC training, I saw the focus on nurses. I think that's what
IPC training is for the whole staff. Yes, but the full nurses.
It's red nurses when you were reading.
Oh,
I'm
sorry.
training for nurses, so for staff.
For staff, yes. It's just for this.
I was going to add, because more importantly, the people who clean our places.
Yes.
I mean, even the non-clinical staff. There was a place where they were saying that everybody goes to visit the director, and then we don't know who those.
And even our doors. The doors, we always hold it in touch. So obviously, everybody needs to be trained in proper prevention. Yeah.
Can I make an intervention?
Please.
So, two comments. That's great. You have a very bold plan. I almost thought you were attempting. Just a note of caution. nice. There are a lot of mentoring in there. Okay. I don't know how many officers you have to lead, because it can be a bit challenging. Now your regular work, and this counts as some additional work you put. So you need to look at your timelines where you have a lot of mentoring going on. Two, there are areas that are not under your scope of influence. You don't have control. IPC training is not under your control. The lab doing the surveillance is not under your control. So you can say collaborate with them and use a longer period, maybe every quarter or something. Because when it's not under your control, you can't see you do. And then I was just wondering why your membership is the head of your duties.
Please, for that I can't give an answer. My boss is not here. Yes, I can't give an answer for that.
Okay. Okay.
Yes, and thank you very much. Please, this action plan that is a few of us that drafted it, but the final one will be edited. Yes. Yes, yes, please. Yes, the final one will be edited.
Just to ask you, one director said, the timelines look at this critically. You can't be doing this, let me say, extra work every month like that. And take it in steps. It's very bold and ambitious, but there are so many activities under it. So I will be happy if you can break it down. For instance, right now you do not conduct PPS. And this training, I mean, we've exposed you to. So I'm hoping that in next year's plan, you will put in how you are going to conduct PPS. Okay. And then the antibiogram, for instance, the lab cannot just get up to, they don't have the capacity as it is now. So maybe in the plan, we are looking at by the end of next year, the lab being supported enough in terms of capacity building and data and training and everything to be at a point where they can now develop an antibiotic.
Yes, thank you very much. Thank you. Please, I think we have a post-test.
Should I give it now or after that?
One last thing, in your training, I'm very happy you already have clinician trainings ongoing. What came up at other facilities is most clinicians are not aware of the aware classification. That's a fact. We've talked a lot about antimicrobial resistance, and a lot is being done. But in terms of what is the aware classification, most, not even clinicians, most pharmacists might not even be aware of the aware. It's funny, but that's what it is. So in your trainings, please let it come out clearly. What is the aware classification? Most people don't seem to be.
Okay, thank you very much. Please note that.
Are you ready to?
Yes, please.
All right, thank you very much. The name again, please. It's a mass speaker. All right, so is it even afternoon? Afternoon. All right, so let me begin by thanking all of us for sitting through to the end of the workshop. It's been quite hectic for the past 2 days. And given the tempo we have, it doesn't feel as if today's Friday. Because most places have been when it's 2 o'clock on Friday, everything comes to a standstill. Even the rainy disease doesn't absorb everything again. But I'm so happy that we've sat through and we've also focused on the training section. And we've learned a lot of information has been shared in this last 2 days, and I'm most grateful to you for sitting through. I also thank the facilitators for the good job yesterday and today. Dr. Drew, Dr. Mary, Mawina. I'm almost changing. Mawina. I'm most grateful to you for the facilitation. There are a few things I've written about, 5 points I've written here that I want to share with us. The first is that, as indicated by the letter that was circulated or signed by the Director General, our goal for coming here is not to establish or was to establish duties. Our goal was to strengthen. And the presumption was that DTC was already in place, and our coming here was to make sure that the loose joints tightened and the roots were also strengthened. So that is what we've been able to achieve. I was also to achieve for the past 2 days. And thank you for being with us. You would realize that all the things which have been discussed for the past 2 days border on systems strengthening. It borders on quality improvement. Because we spoke about DTC, we spoke about AMR, we spoke about what? Oh,
IPC.
DTC, AMR, and what? IPC. We spoke about issues pertaining to quality improvement. We spoke about clinical care issues. So all of them are inextricably linked. So what we came to do here was basically a system strengthening workshop that we came to organize. And we realized that the issues are also cross-cutting. It came to the fore that no one discipline can achieve all. We require the nursing fund, we require quality improvement team, we require IPC team, we require prescribers, we require pharmacists, technicians, PAs, everybody, all hands on them. So it was a cross-cutting thing that we came to do. And it basically hinges on strong team building and teamwork. I think we also tap on the role of leadership. Leadership is everything. And we expect the leadership to take this issue up and drive the agenda forward strongly. One thing that we kept mentioning over and over was emphasis on data. Interestingly, Mauna did not come. Is it Mauna? I always said Mauna. There was this quote he used to project when he went to Isabel. Who remembers that? The team that went to Isabel. Okay. He said that you can't, it's one of the quotes I like so much in management. He said you can't improve what? You can't measure. You can't improve what you can't measure. And the person that accesses, in case we take the word improve, what substitute was no cannot replace it with. To try to say any ideas. You can't improve what you can't measure. Be easy. So that will take away, improve, and substitute with another way. So I try the same way. What will you do there?
Enhance.
You can't enhance what you can't measure. Okay, what again? Upgrade what you can measure. Okay. Yeah, so, all right. And I also say that you can't manage what you can't measure, or you can't monitor what you can't measure. Yes. So, underlying all that we have discussed is 2 days. Having credible data to enable us monitor, measure, and improve everything that we are doing. Data in relation to antimicrobial consumption, data in relation to antimicrobial use, data in relation to the emergence of antimicrobial resistance. So data for me is so. And the final thing I would want to touch on is the issue of continuous education, which Dr. Mensa mentioned over and over again. The system that we find ourselves working in is a learning system. It's a system of continuous education. If you don't read, if you don't study, if you don't make conscious effort to upgrade your knowledge, your skills, and your competencies, you are going to be left behind. And he said, one quote that I also leave us with, that when teams are set up, you are only as strong as you assert yourselves. So going forward, we expect us to assert ourselves in the very responsibility that God has given to us through the leadership of the institution. So once again, on behalf of the Director General of Ghana Health Service, and also on behalf of Director ICD, Dr. Rosbury, and on behalf of the Deputy Minister, Dr. Mensa, on behalf of the team, and on our own behalf, we want to thank the management of Shai Osu Doku. Is it municipal or district hospital? District hospital for hosting us for this duties. I will thank our financiers so much who supported us. IHP, all right, supporting us. Carrying us all the way from Accra to Shai Osu Doku on Thursday, also on Friday. We are so grateful to you. She's promised us that next year she's going to make sure that a lot of healthcare facilities are added onto this very program. You know, initially, Shai wasn't on the agenda, you know that. Yeah. Initially, Shai wasn't on the agenda. I will not tell you what went on behind this. But your pharmacist was very, very smart. She connected us somewhere. That's how Father Shai ended up on the agenda. So we thank you so very much. And we hope that we come in next year, we're going to see tremendous improvement in quality of healthcare in IPC, in antimicrobial utilization in this facility. Thank you very much.
So, first of all, I want to once again apologize for not being able to sit through the whole training today. Another equally important meeting I had to sit, but I guess my colleagues did that on my behalf. I want to thank directors from Head of Pharmacy, Director of ICD, and staff from Ghana Service for finding it appropriate to push Shai into the future. I wanted to know what happened at the end, but I guess whatever she did, it worked, and it worked well for our group. It's always good to improve on our systems. I tell my staff that every institution that is built on this, people and ideas might not be able to stand. But if you build it on systems, that institution always outlive whoever believes the institution. So anytime there's any program that seeks to improve on our systems, we work on it. And I guess that is what this has done. ETC is important in terms of looking at the outcome for our patients, stewarding what we give to them. We've not developed any antibiotics for the past 40, 50 years. Our colleagues in the UK are still using ampicillin, but we are not using ampicillin because of what we have done to the drugs that we have. If you come in and you have to prescribe vancomycin for you right now, you might have to now look for a loan to be able to sustain you. But maybe a normal CPRO would have done the trick for us. So it means we have a lot of work to do to protect what we have. And in the fight of AMR, even 1% gain is very important, because that 1% gain, you are not looking at 18%, you are looking at the impact that it has on the patient that you are seeing. So I guess we now have our charts done for us and what we are supposed to do. And I believe that if they are able to incorporate all that we've been told, all that we have shared, our ETC will improve, our patients will have the best outcomes of it. And of course, the health system that we are working in will be a good place to stay. So once again, I want to thank you for coming. And I can promise you that should you have any opportunity to come back on ETC, whatever data that we showed you yesterday will be a much improved data that we showed you, because that is what we are doing. I wish you a safe journey back. If you came in a Land Cruiser, it would be a good journey back. If you came in a small car, you will feel a bit of the bump, but we can reassure you that next year if you come, it will be a good journey. I wish you a fruitful weekend. And always come back when you have a program with that. Don't leave us out of the program. Thank you. Thank you.
Thank you very much. We've really had a fruitful training. And please, would like to ask Alaji Hamza to give us a closing prayer as we go and enjoy our
In the name of Allah, all thanks and praise be to Allah. First off, the door of resurrection. Allah is you we worship, and you we ask for guidance. Guide us of His kingdom. Amen.
Thank you very much. Please, we are most grateful to the team. We are really appreciative. Thank you. And God bless you.
God bless you.
Extension.